Good morning again, honorable members. You are all very welcome to this meeting. Everyone who has joined us this morning. This is a meeting of the Portfolio Committee on Health, and we are receiving our last two presentations, oral presentations of the National Health Insurance Bill. We will be having two presentations this morning. We would also want to welcome the members from the ministry who will be present this morning. I do not see the Congressman present this morning. He usually when he does join us, I hope he will give me an indication, or Mr. Joe Cutler will give me an indication that he has joined us. Also welcome to Mr. Joe Cutler, the PLO of the Minister, also to members of the department officials who joined us this morning, members of the media, and members of the presentation teams of both the EA and the ANC. Ms. Machalamba, if you could just give us attendance and apologies this morning. Thank you.
Good morning and thank you, Chair. Present is Dr. Jacobs, Ms. Geller, Mr. Sokacha, Dr. Harvard, Ms. Clark, Ms. Wilson, Mr. Ishmael, Dr. Tembe Kwayo, and Mr. Van Staden. Ms. Chiro will join the meeting later, and Ms. Sukers has submitted an apology. She won't be attending at all. Thank you, Chair.
Thank you very much. Can you also give me an indication, Ms. Machalamba, of any media coverage this morning? I see we do have the parliamentary live streaming on the system.
I'm still waiting for Yoli to confirm the media coverage. Thank you.
Thank you very much. Honorable members, before we proceed, let me just remind you that this virtual meeting is deemed to be the precinct of Parliament and therefore constitutes a meeting of the Committee of the National Assembly for official purposes only. In addition to the rules of virtual sitting, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in the sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute the microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screen, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. In using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjection. We will now continue with the business of the day. We have Ms. Sibiwe Kwakume, Mr. Bernard Horn of the DA to do the presentation. You must go straight onto your presentation, introduce yourselves. Ms. Kwakume, very welcome back to us. You only left us for 2-3 weeks, and now you're back with us.
I clearly can't stay away.
You can't stay away, Honorable Kwakume. Thank you very much. You can introduce the rest of your team and then carry on with the presentation. You know the format here. Thank you.
Cool. Thank you very much, Dr. Jacobs, and good morning to the parliamentary team and to the members of the Portfolio Committee and everybody else. This morning, the Democratic Alliance will be making our submission as we had requested to do so when this process was opened back in 2019. I'm joined by Advocate Werner Horn, my colleague who serves on the Justice Committee, and the two of us will be making the presentation this morning. And so, with your permission, Chairperson, we would like to jump in.
Thank you. Welcome.
Sorry, I'm just trying to make it a slideshow. Right. Thank you very much. We're going to get started, and you will be able to see that the offering that we have here is divided into two. I will be doing the introductory remarks, and then my colleague, Advocate Horn, will be able to start talking about the legal challenges with the bill, and then I will then conclude with some of the more substantive issues that we have with the bill. As I think it's first and foremost, I think it's quite important for the purposes of this committee, because of the work that you do, for us to unequivocally state that we support not only do we support universal healthcare, but we believe that we're the advocates of universal healthcare. It's how the rest of the world is moving. That's the direction that the world is moving in, and we think that it's absolutely important that South Africa does the same. Also, as particularly considering the deep inequalities that exist within our healthcare system, our view is that this is the way in which we would be able to equalize and make sure that all South Africans have access to quality healthcare. However, the Democratic Alliance, again, categorically does not support the NHI bill. And I think it's an important point to make, and a distinction here to make, that the NHI bill is but a piece of legislation. It is not universal healthcare itself. It is a tool that the drafters sought to make, the drafters sought to realize universal healthcare. And therefore, if the bill were to fail, it does not mean that South Africa, or at least the people who have identified what is wrong with the bill, do not support the UHC as a principle. And so this vehicle, which is the NHI bill, we believe we do not support the bill for a number of reasons, which we will go through today. But more importantly, we believe that the bill as it is drafted today and right now, it will not reach its intended objectives. And that for us is the big and overarching reason that it will not be able to bring about universal healthcare, which is what is needed. We know that for the universal healthcare to be successful, we need a capable state, political stability. We also need a particular economic environment. And so we will go into some of these things later in the presentation about how, in the current state of our country, firstly, UHC would struggle to take root. But more importantly, this bill is not going to bring about quality access to quality healthcare for most of South Africans. And instead, what it will do, it will open up this fund that the bill seeks to establish to massive, large-scale corruption. But perhaps before we get into those, let's get started with the particulars and the legalities with the bill at the moment. Werner, I'm going to hand over to you.
Thank you, Suwiwe, and thank you, Dr. Jacobs, and members of the Portfolio Committee for this opportunity. It's at this stage an interesting experience to sit at the other side of the table. Chair and members of the committee, we have identified in our analysis of the bill a number of really material issues, constitutional in nature largely. We firstly of the view that the bill was tagged incorrectly, and that it has a massive financial consequence, but more importantly, given the fact that in Section 49, it contemplates additional tax to be imposed on the citizenry of this country, we strongly of the view that that specific provision in the bill necessitated a tagging as a money bill. And it is tried now that incorrect tagging ultimately is a material flaw in the process of legislation. So we urge that be revisited. Then secondly, and at the outset, Chair, we are very worried that Section 27 and Section 7 of the Bill of Rights are not given effect to or complied with in terms of the way the bill is phrased at the moment. These two sections makes it clear that on the one hand, everyone, and on the other one hand, all people in our country are entitled to the benefits that would flow from the way we give effect to the Bill of Rights. So the limited way in which asylum seekers would enjoy access to quality healthcare services, in our view, cannot be regarded as anything else but unconstitutional. Then another Section 7(2)(f), in our view, in an unconstitutional way, undermines, dilutes, and ultimately defeats the provisions in our Constitution which gives provincial governments a competency and a parallel competency in respect of healthcare, the way in which this provision centralizes decision-making around key structures that is to be set up by the NHI bill in the national minister, in our view, ultimately will render this provision as well as unconstitutional. And we urge that this be addressed during the deliberations and the redraft under the guidance of the Portfolio Committee. Other concerns regarding the powers of the minister. We firstly of the view that if one reads in totality the powers of the minister, but more specifically the powers the minister enjoy regarding the making of regulations, that this undermines, threatens, and ultimately in an unconstitutional way negates the principle of separation of powers, which runs as a golden thread through our Constitution. If one looks at Section 55 of the bill, it's quite clear that the matters on which the minister is allowed to make regulations is not merely administrative in nature. Some are executive in nature and others are legislative in nature. And therefore, for the bill to merely require from the minister to table regulations in Parliament without spelling out any oversight or parallel functions for Parliament in order to adopt or reject regulations, in our view, will be fatal if one reads that in line with the principle of separation of powers. The second issue is the powers of the minister to appoint the board. Now, we strongly of the view, given the fact that the board ultimately seems to be an oversight and advisory institution, which in an ideal world must have that perfect tension or create that perfect tension in order to deliver quality services and optimal functionality. We strongly of the view that it cannot be left that the minister, without carefully delineated processes, are allowed to appoint the board. So in the most recent times, we've seen from the Zondo Commission reports that has already been released, Chair, that we as a country have a massive problem when ministers enjoy a more or less unfettered power to appoint boards, even though those were in respect of SOEs, and this is strictly speaking not an SOE. We say that it's very similar in nature, and we say also that based on what we've seen unfolding in the years of state capture, Parliament now, on the one hand, has a duty to ensure that public participation, parliamentary oversight, and accountability is in place in respect of appointments of boards. But we also say that we most likely are at the point now where our courts will for sure not turn a blind eye if the provisions around the minister's authority to appoint the board is attacked. And that it is incumbent upon Parliament to learn from the mistakes of the past. Then furthermore, the so-called investigative unit is a big worry to us. There's firstly quite clearly a very clear lack of independence on the part of this unit in the way it is currently phrased in the bill. But we're also worried about the duplication of functions that already rests with the Public Service Commission, the Public Protector, and the SIU. And in I want to say, a worst case scenario, I think we believe there's also a case to be made out that it can encroach on the focused and reserved powers of the South African Police Service to as the single body in the country responsible for the investigation of criminal offences. And we urge the committee to relook at that and to strengthen those provisions in order to not fall foul of these trap holes. Then a very important further objection from a constitutional point of view, Chair, we have is the erosion and the possible abolishment of choice through the NHI bill. So it's quite clear that the bill will have a massive impact on the continued existence of private medical schemes and private medical care. And we are of the view that if one looks at the very simple way in which the minister enjoys authority to ultimately determine, once the bill is fully implemented, what healthcare services may be rendered in a private manner, that ultimately, if not in practice, it at least holds the very real danger that we will see abolishment and prohibition of private healthcare by stealth. And that can not be what this Parliament intends, we hope, for a variety of reasons, which I will unpack just now. So it is about the choice patients and citizens must enjoy, but it's also about the choice medical practitioners, in our view, must enjoy. And in that sense, the freedom and the right to practice a trade or a profession as enshrined in the Bill of Rights, in our view, will be or could be redefined to a point where the only real choice people will enjoy is whether to practice as medical practitioners or not. And if the further one even does not even want to call it regulatory framework around medical practice is to be left to the minister alone, then in our view, it is more than a limitation, more than a justified limitation on their freedom to practice trade or profession. It is really holds the potential that this freedom be taken away altogether. And in that sense, we're of the view that it's not even a limitation, but even if it is regarded as a limitation, it cannot be a justifiable limitation. So, in addition to what I've just said now about the erosion of choice, Chair, we have also a massive problem in the way that it would seem this bill seeks to attain equality in respect of healthcare in a regressive manner. And in our view, if one embarks on a contextual interpretation of the Bill of Rights, and if one further takes into account that the whole issue of quality ordinarily centers on what is called unfair discrimination, to which some people are subjected because of the let's say the actions of others, be it the state or private citizens. Then we say that in this scenario, it is quite different, in the sense that it would now seem that in order to attain equality, the bill seeks to take away privileges and rights already enjoyed by some, which is regressive in nature, and in our view cannot be justified in a scenario where the inequality is really caused by inadequacies in terms of the current system. So therefore, the solution, in our view, in a lawful and constitutionally compliant way, cannot be to take away from some who enjoy more than others. It must always be focused on increasing the opportunities that those who have historically not enjoyed the same opportunities. So an increase in opportunities is what the bill should aim for, but what we rather see is that it works in a regressive way, circling back to the what we see as the possible abolishment of private healthcare by stealth. It seeks to regressively take away that which some enjoy in terms of access to medical healthcare. And in that sense, we're of the view that it cannot pass constitutional muster. In this respect, we lastly want to point out that the limitation clause makes it quite clear that any limitation must can only be justified if it is a limitation that is to be reconciled with an open society. And in our view, if one looks at the accepted characteristics of an open society, the main characteristic of an open society is individual freedom or autonomy. And based on what we've pointed out up to now, we are strongly of the opinion that this bill does not merely limit freedoms, but in many respects takes it away, and therefore it will fall foul of the requirement that it is not justifiable in an open society. Thank you, Chair and Siviwe.
Thank you, Advocate Horn. And so now, colleagues, I'm going to go into the the specifics of the bill. As you've seen, we've separated our presentation. Advocate Horn has gone through what are some of the key constitutional concerns we have with the piece of legislation in itself. And now we're going to go through the specific elements of the bill, particularly why it is that the Democratic Alliance opposes this bill. Number one, and I think that most crucially, Section 25 of the bill talks about the establishment of a benefits advisory committee, which will be responsible for determining and reviewing what healthcare services and benefits there are. We think it's important that in the draft legislation that it really be included, because of course what we are asking South Africans to do is to entrust that this benefits advisory committee will be able to really craft together a full and comprehensive package of care. And so we think that the bill here, particularly this section, is vague as to what services and medications will be covered or excluded under the NHI. And this is quite important when one wants to look at the buy-in for a legislation of this nature. Number two, while, as Advocate Horn has said, while the establishment of the NHI fund will be separate under a separate section of the Constitution, the reality is that it is managed in a way that looks exactly like the way that SOEs are managed. And we cannot, in the deliberation about this bill, divorce South Africa from the history that we have of poorly managed SOEs, many of whom have needed bailouts, and many of whom have essentially failed in their core mandate. And what is quite evident, even from the State Capture Commission, is that SOEs, and particularly ones that run well, need a capable state with political stability. And unfortunately here, colleagues, we are unable to have an entity like this one go towards the, look like Eskom, Denal, or the SABC, because of course we are looking at the lives of people. And so we are opposed to the way in which the bill proposes the establishment of a fund which will run which will be run as a state-owned entity through the pooling of public funds, especially because there aren't enough accountability mechanisms to make sure that that fund is run well and that it is not stolen, which I'll get to shortly. We also have a concern, particularly here, with the referral pathways that the bill speaks of. Section 7 of the bill compels users of the fund to access healthcare services at a primary healthcare level as an entry into the system. Now, our view is that because there has never been an investment into the healthcare system, essentially what this bill is saying is putting the horse before the cart, because to impose that all South Africans must first start at a primary healthcare level is to assume that all South Africans have access to quality primary healthcare in all the different parts of the country within the 5-kilometer radius, as is per the international norm. And we know that this is not, in fact, the case. And so we believe that the imposition of this section of the bill is both a burdensome provision and, in fact, may place unnecessary pressure on the healthcare system, where some services are closer to the people than others. And so we believe that it can even be a hindrance to the access of care for citizens. The bill also imposes conditions on which treatment may be refused and does not allow for an obtaining of a second opinion or seeking alternative forms of treatment. In Section 7 of the bill, it states that a healthcare service provider may, on a number of these provisions here, really decline giving somebody the kind of medical care that they need, either on the basis that they don't think it's necessary, or that it's not cost effective, or that that whatever product that person needs is not in fact included in the formulary. And our view here is that treatment can be, because of course people are people, having that section imposed in the bill can be a problem, because what you can have is you can have healthcare providers refusing people treatment on unreasonable ground. Also, it means that people may not be able to obtain a second opinion. And there's a reason why that is provided for in a healthcare setting. And so we don't think that the imposition of that section of the bill is necessary. And actually, we think that it will go against the principles of ensuring that people are able to access their healthcare when they need to. And then lastly, particularly on this section, it's unclear also whether or not, how the issue of emergency and critical medical situations will be handled if this section of the bill is included. And then we also have a particular concern around how healthcare providers can treat patients. Section 39 states that a healthcare provider must adhere to treatment protocols and guidelines, including prescribing medicines and procuring healthcare products from the formulary. We are of the view that, again, this may limit the healthcare professionals' ability to find alternative forms of treatment. We know that currently healthcare providers are guided by various groupings and their various bodies that they belong to, and they are ethically bound by the bodies that they belong to. But we believe that the inclusion of Section 39 here in this part really does limit the agency and even stifles innovation in a sense in the healthcare sector, because it's very, very much formulaic. And number 6, one of the things that we're also very concerned about is the clear erosion of provincial powers. Again, I mean, I think this is not just about saying the erosion of provincial powers is a problem in and of itself, but first of all, the provincial powers are enshrined in the existing National Healthcare Act of 2003. And ultimately, that act says and states that provinces are responsible for their running and the rolling out of healthcare services, while national government is responsible for setting policy and for setting the vision and allocating funding in the form of equitable share. But what this bill then does is that it completely blurs those lines and undermines those provincial powers, because there are some instances where the national department may have to take on the powers of some central hospitals. We are of the view that this is rather problematic because, of course, we think that it's important that healthcare services are closest to the people. What we don't want is a situation where there's a centralization of the provision of healthcare and that it is completely removing the actual users of healthcare from those who are providing the healthcare service. We think that the closer the healthcare service is to the people, the better it is for them in terms of healthcare outcomes. Then the other problem that is that we've identified in the bill, Chairperson, is the issue around the fragmentation of the healthcare system. As I've stated in the previous slide, in some parts of the bill, it's envisioned that particularly tertiary hospitals will be under the management of the national department, while other hospitals, perhaps regional hospitals and primary healthcare facilities, will be under the management of provinces and local governments. Our view is that we should not be moving in this direction. We should be able to have primary healthcare facilities all the way up to tertiary healthcare, or all the way to tertiary hospitals run by provinces, so that again, it's not cumbersome for somebody who needs to be able to access not only their documents, who needs to be able to access their medical records, that the system runs well. And we think that here, it really takes away the efficiency of having a very well run healthcare system. And of course, there's a lot of literature, Chairperson, around the fragmentation of the healthcare system and how to combat that, and how essentially to try and not do that. And we think that the bill essentially does that exact opposite. It takes the power away from people from being able to hold those who provide the services closer to them. And as Advocate Horn at the beginning has stated, that this does remove the autonomy of South Africans to choose their own healthcare, as it provides for the Department of Health as the sole provider of healthcare in the country. And basically private healthcare providers will be contracted by the state. And so while this in itself may not seem like a massive issue for many people, the reality is that we're of the view that we need to get our healthcare service to the level where everybody can choose where they want to go, and that the quality of healthcare services is not any different whether you go to a private healthcare facility or a public healthcare facility. Then I want to then zoom in particular to the poor governance structures which are introduced by this bill. Under Section 12, the board will be established, and this board will be mandated to manage and govern the fund in accordance to the PFMA. However, in terms of Section 12 of the bill, the minister is empowered to appoint suitable candidates to the board after recommendations are made by an ad hoc advisory panel. Now, we're of the view that this is, firstly, very poor governance model to have a politician appoint a board that will essentially manage a multi-billion rand fund that will really manage the entire healthcare system of the entire country is a recipe for disaster. There's nowhere, there are no checks and balances here where we are able to see where where perhaps, there's an inclusion of Parliament appointing the board, which is something that could be considered, where at the very least the board has some level of autonomy and some level of independence. But here we see a situation where the board is appointed by a political principle, and this section of the bill really does give the Minister of Health unvetted powers, and we don't think that this is useful when it comes to governance. And I do want to hasten to add here, colleagues and chairperson, that it's important as lawmakers that we don't legislate with the view that you will get the best person for the job. You legislate with the view, or at least with the worst possible minister in your mind. Because if you legislate for the best possible minister in your mind, then you will not be able to put legislation in place that will make sure that you protect actually the public finances. So it's important to be able to say, how do we build in accountability mechanisms? We saw during COVID corruption what happened, and so we've got to make sure that we take the lessons that we were able to see, all of us there. And this is a very important provision there. And then the other issue that we have taken on with the bill is under Section 32, where the minister is empowered to introduce proposed amendments to the National Healthcare Act. Only just to say here that with the current bill, it's unclear as to how provisions of other existing legislation will be dealt with, considering the fact that should this bill go ahead, certain sections of the National Healthcare Act then will cease to be relevant at all. Then the next, there's no reasonable accountability measures as the investigating unit is situated within the fund, which is effectively managed by the minister. Again, very poor governance models. And if you read any kind of literature around how you build accountability mechanisms, I mean, this is possibly one of the worst, because you've got a situation where the board is appointed by the minister and only by a recommendation. A recommendation is not strong enough. Only, a recommendation is made to him. He gets to choose, him or her gets to choose the board. And then the investigating unit, which will essentially be investigating any possible corruption, will essentially be located within the NHI fund office. Our view is that this is not an independent body, and it's not protected from undue influence. And considering just how much money will be in this fund, we think that this is wholly inadequate and should not be considered at all. Then there is also no clarity for us on the composition of the investigating unit. If you look at Section 42 of the Act, and so we are worried again about the impartiality of this unit, because it's quite important. We've seen the continuous hollowing out of some of our criminal justice system entities, and the last thing we need is a toothless unit that sits within a political office to try and investigate corruption if it arises. And then we had also several concerns relating to the eligibility of the board members. We think some of the provisions in Section 13 are rather broad and could essentially be open to abuse and manipulation. And so we really think that, once again, this is not a process that should be managed by a minister. We do not believe that this is a function that should sit within the executive, and that we think that this appointment process essentially bypasses parliamentary structures, where we can, in effect, make sure that Parliament has an oversight role to play. But you cannot have the minister as both the player, the referee, and everything else, when in fact there are parliamentary structures that can play that role. And then the other section of just want to check on my time. The other part of the bill that we are concerned about is the imposition of the proof of address for the registration of the fund in terms of Section 4. We believe that, again, very simply, I mean, in a country like ours, with deep inequality the way that we do, it might be a barrier to access to many South Africans who may not be able to provide the required documentation to receive access to services. Our view is that this section is added and really shouldn't be, considering the myriad of reasons that the Department of Health even is aware of, that many people may not be able to produce this proof of registration. Then, more importantly, also, I mean, my colleague had stated this right at the beginning with some of our legal concerns, but Section 4.2 of the bill also determines that asylum seekers and illegal foreigners will only be entitled to emergency medical services. Now, Section 27 of the Constitution states very clearly that everyone has the right to health care, and it does not expressly exclude anybody on the basis or on the grounds of a status as either an illegal foreigner or an asylum seeker. And so we believe that simply saying they will only be given access to emergency medical care, which in effect is not even defined in the bill, we believe that it's actually in contravention of this section of the Constitution and is discriminatory in nature. Then the reason that we've stated here, it's clear that medical aids will cease to exist. However, what we're unclear of, again, is whether or not there will be a scenario where the medical aids and the private healthcare sector with the public healthcare sector can coexist, and what the role of medical schemes will be. Because again, I think it's important to note some of the lessons that came from COVID-19, that in fact, it's not useful to vilify the one sector and to play it up against another. If we saw how COVID-19 was managed, we saw that in effect, what really worked was that a collaboration between the private sector and the public sector is really what pulled us through in some of these moments. Then the rationale of pooling funds for the NHI, our view here is that this rationale is in fact not feasible. But also more importantly, we don't believe that it goes to the nub of the problem. Pulling funds and throwing money at the problem doesn't fix the challenges, which is what we said right at the beginning. To say essentially what you need is a system overhaul. You need to overhaul the entire healthcare system to make sure that from primary healthcare level all the way to a tertiary healthcare level, you've built in systems in place and you've made sure that there's investment in infrastructure and the like, and accountability mechanisms. But what is not going to help you is simply pulling funds and throwing money at the problem when the systemic challenges have not been dealt with. And so we're of the view that there are many other issues that need to be dealt with. And this bill is very myopic in that it only deals with a funding model, but does not deal with how do we bring about real universal healthcare. Then very importantly as well, Chairperson, we've got a massive issue with this bill in so far as it imposes an additional tax burden in South Africa. Number one, we believe that South Africans have already been squeezed dry. A lot of South Africans are stretched. The tax base that this bill will rely on is shrinking by the day. And we believe that it is really impractical to expect South Africans to have an additional tax burden imposed on them. And we are of the view, as you'll hear right at the end of my presentation, that there is a way to overhaul the system in a way that can take into consideration our current budgetary allocation and how we do that. But to impose another tax burden on South Africans is really, particularly at a time like this, is honestly possibly could be a death sentence for many. And then the other issue, of course, is that as the bill stands, I mean, NHI is unaffordable and it's fiscally unaffordable, as has been confirmed by Treasury. And as we know, over the past 2.5 years, we've been in constant contact with Treasury, where Treasury has in fact has said categorically that fiscally the NHI cannot be funded. And as we've seen over the past 2.5 years as well, that in the budget allocation, we're seeing that there's been a defunding or a lack of funding for NHI. There's been essentially no movement because we believe that there's no money. And so that's why we're of the view that massive aspects of this bill are simply not going to take off. So unless the committee goes back to the drawing board, we're not going to be able to see any kind of change in the way in which our healthcare system is done. And again, the principal point to make here, I'm going to run a little bit faster. The principal point to make here is that there were pilot studies that were done with regards to the effectiveness of NHI. And effectively, I mean, as per the report that we saw, the NHI pilot project failed. So it makes no sense to us why then the department, or at least the committee at this stage, would okay a bill that has effectively, when you looked at its testing stages, you realize that there were many failures. For instance, inadequate planning was one of them, insufficient mechanisms to monitor progress. And we had at a massive cost, these pilot studies failed. And there isn't a sense from the department, and at least we're raising this concern with the committee, there isn't a sense of how we're going to deal with the massive failures of the pilot projects. We're of the view that also there are a number of feasibility studies which need to be taken on board, a financial feasibility study, an institutional feasibility study, and a technical review, which we've listed here, but I'm going to move on pretty quickly. And we are also of the view, our other concern is that the implementation of the NHI will lead to a brain drain of critical skills. We know that there are a number of critical skills that we need in our healthcare system. And so a lot must be done to try and preserve that, instead of simply having a very hard core approach that says you either join in or you are out. And this is what we talk to here in this slide, where we talk about the fact that South Africa has a shortage of 34,000 nurses, and essentially really there are massive medical practitioners who are leaving the country en masse, and we need to be very mindful of that. And so we need to be able to make sure that in your deliberations as a committee, that is something that is taken into account. And then just to say here, I mean, I'm going to go by pretty quickly here, Chairperson, just to say that the bill, of course, the white paper in the bill was introduced years ago, I think back in 2017, if I'm not mistaken. And then the bill in itself, the draft bill, was then tabled in Parliament in 2019. And since then, there has been a global pandemic, there has been decreased economic growth, millions of job losses. And so our view really is that this bill should go back to the drafting phase, because it does not in any way take into account some of the lessons we learned during COVID-19, some of the economic environment that we find ourselves in, particularly the fact that this bill is now, in the current context, truly unaffordable. And as we will hear this afternoon during the budget speech, we'll probably hear exactly the same thing from the Minister of Health. And this slide here is just to state again that there's a projection that we are sitting with a 380 billion rand deficit. It's unclear then to us as to how we're going to be able to afford to do healthcare in this way. Of course, we must never say that healthcare quality healthcare cannot be delivered because of financial reasons. But the reality is that we've got to take those into account. And we are of the view that there are ways to roll in and bring about universal healthcare within our current budgetary envelope, whereas this bill really has unrealistic expectations to an economy that really can't handle it. And of course, this really emphasizes the point about a shrinking tax base and how unemployment is becoming a big problem. And of course, again, this emphasizes the fact that there are lessons to be learned in the pandemic, and those need to essentially be sewed into the draft of the bill, particularly how we have experienced how centralization in effect was a problem. The centralization of the procurement of vaccines was an issue where we essentially saw that bottleneck really cost us in the end. And when we started to see how things really worked and worked well, colleagues, how we saw things working and working well is when we saw a collaboration between the public healthcare sector and the private healthcare sector. And the department will tell you that that partnership is really what brought us to the higher levels of vaccination and the like. And here, just to emphasize again, lessons learned, we have 13 billion that is being investigated in irregular contracts. And what we can't have is a situation where this bill does not have accountability mechanisms that really go to the core of preventing this large-scale corruption like we saw and with the implication of the previous minister and the like, what we saw before. We need to make sure that it does not happen again. And this is just to illustrate the rise in cost of medical malpractice and how some of the provisions in this bill could lead us to a point where, in effect, this kind of amount rises. And so really our view, again, as we conclude, that as a Democratic Alliance, we really think that we stand for universal healthcare access to all citizens, but we disagree that this bill will get us there. We think that it misdiagnoses the problem, and therefore it needs to go back to its drafters. We have here an alternative that the committee can consider, which has been submitted through to you, where we think we can have a system where we've got universal healthcare, but not through the current funding model that is proposed by the NHI bill. And of course, we know we've got some lessons that we've learned in the Western Cape as well, where we've got one of the best run healthcare system in the country. And of course, we don't think that provinces should be played up against each other. We think that there should be a great learning opportunity across the board. Whichever province does something better, there should be learning opportunities with others. Then in conclusion, Chairperson, so that I do not run out of time, because I want to emphasize these points. Number one, that we must remember that as the DA, we support and advocate for universal healthcare, but we are of the view that this bill will not achieve that. We think that this bill is only a funding model, and it speaks nothing of a holistic overhaul of a broken health system. We think that this bill will not achieve universal healthcare. In fact, the way that it is drafted, it is the very antithesis of what universal healthcare will be. We think that this bill misdiagnoses the problem with the South African health system. It misdiagnoses the issues of corruption, mismanagement, and poor use of public resources. The bill simply vilifies the private sector and does not envision it as a partner to achieve better health outcomes for all South Africans. And we think that the sweet spot lies in the better collaboration. The bill, again, was drafted before the global pandemic and does not include the lessons that we have learned and the value of partnership across the board. The bill, we disagree with it because it will impose an additional tax burden to already struggling South Africans when universal healthcare can be achieved within the current budget allocation. Again, the bill does not make provision for the investment in the current healthcare system. We've got to make sure that we invest in the current healthcare system if we're going to be able to roll out UHC in an effective way. The bill pulls funds from the provision of healthcare and throws money at the problem. And we believe that it won't fix the problem if you don't fix the system in itself. The bill imposes poor governance structures without any accountability mechanisms. The political appointment of the board is a massive problem. And as we've seen that it can be open to corruption, as we've seen in the past 2 years. The bill does not include any oversight role by Parliament to hold the minister and an independent board to account. The lessons from COVID-19 alone should ring alarm bells for the committee that when there's no role being played by Parliament, we will essentially have massive problem. And then second, lastly, the bill has many constitutional pitfalls which will erode provincial powers, fragment the healthcare system, deny access to healthcare for asylum seekers and foreigners. We believe that the bill respectfully should be sent back to drafting to take into account the many issues that have been raised in the public hearing process. We believe that legislation drafting is the role of Parliament, and that all the work that has already been done by Parliament with the public hearings should be taken into account. You have in your arsenal, colleagues, all the inputs that have been given by the various organizations that have come to present. And we think that the bill should go back to at least encompass all of those changes. And we are of the view that it needs to go back to drafting, and thus we cannot support the bill in its current form. Thank you very much, Chairperson. I'm going to try and stop the... Yes.
Thank you very much, Honorable Bakube, Honorable Board. Very much for your presentation. There are a number of members who want to raise questions with you. Wilson, Ismail, Clark, Tukacha, Harvard, Gela, Munyai, Lengua, Siwela. I'm going to repeat. Wilson, Ismail, Clark, Tukacha, Harvard, Gela, Munyai, Lengua, Siwela. I noted there was a hand raised of Honorable Sheikh Imam, but he seems to have lowered it again.
Yes, Chairperson, I did that because I needed to join the other meeting, so I thought I could get a quick bite
You may
on
let
this.
me give you the opportunity quickly. No, I will give it to you.
Thank you very much, Chairperson. Thank you very much, Chairperson. I've just got, I think, one question, and that I think is paramount. We do accept and understand that there are serious challenges. We have fiscal constraints. But at the same time, our people are dying. Particularly people that are over 60 years of old are being turned away by the hospitals. The levels of inequality in the healthcare is a massive problem. If you don't have medical aid, which is the majority of the people in this country don't have, or don't have the luxury of that, because they don't have the luxury of having the next meal, these people have no healthcare and are actually dying. Now, can you tell us what is the alternative, given the fact that you accept and understand that we have challenges in terms of state-owned entities, the way they are run, in terms of the fiscal constraint and things? What happens from now? Should we not start somewhere to be able to start providing this better healthcare, equal healthcare facilities to all South Africans? Do you accept and agree that every life is valuable, every life is equal? And the problem we're having is for many years, many of those vulnerable people are left out of the system, okay? And this goes for every province in the country. What would you suggest that we do in the interim to try and provide universal health care to everybody in this country, irrespective of the economic or financial situation they find themselves in?
Thank you very much, Honorable Sheikh Imam. You're welcome to leave as you had indicated on the chat. Thank you. Now
Thank
we
you
will
very much.
continue with the rest. Honorable Wilson.
Thank you, Chair, and greetings to the committee this morning, and thank you to Saviwe and Advocate Horan for your presentation. I have a couple of questions. Indeed, I agree that the amount of money, and because it has a tax imposition on South Africans, that this should indeed be a money bill. It's not tagged as a money bill. And it is questionable then what the role becomes of the Treasury. Because if it's not registered as a money bill, it becomes a little bit harder to manage without a Treasury involvement. Perhaps one of you can give me some information on that. Secondly, there's an age-old question. What came first, the chicken or the egg? And I raise this particularly because NHI makes large sections of the current National Health Act mute. It affects the current National Health Act, and it makes a lot of those sections in that act very moot. They have to be, they can no longer be part of that act. So if the NHI were to pass, and we know it can't at the moment because of the unconstitutionality of large sections of it, but even if there were changes and considerable changes to this bill, one would then have to assess how that is going to affect the National Health Act, because it makes large sections of that unconstitutional. So what does one do before this can even be implemented? Surely, and we know it's a long and unholy process to get amendments made to current bills to fit in with other bills. And hence my question, what comes first, the chicken or the egg? It's one thing to say we will implement the NHI, but we can't do that until we've assessed the implications on the other bills that are related to it. I want to speak sort of completely off the angle here a little bit, and I'm going to raise a tax issue. sugar tax was imposed in this country. Okay. The principle behind that tax at the time was because of our very high sugar usage in this country, our excessive cases of diabetes and sugar-related diseases, that a sugar tax should be imposed. Now, that sugar tax was supposed to be set aside for the promotion of health and dealing with issues like diabetes, etc. Now, we introduced a tax. Nobody can tell us how much tax was actually garnered from that sugar tax and where it's actually been spent. And in actual fact, the opinion is that it's actually gone into the national fiscus, which was not the intention of that sugar tax in the first place. Are we not running the same risks with the NHI fund, where we're going to have no idea if this is being appropriately spent? Because there's nothing in this bill that tells us how this fund should be. In other words, the way it needs to be spent is not categorized. It is a concern for me. I'm glad you mentioned the separation of powers. I think that is a huge issue. And while we're talking about separation of powers, there is a section of this bill that principally entirely cuts out the Competition Commission. Now, the Competition Commission is there for a reason. This bill implies that we should have a single purchaser, and that purchaser will dictate as to where you may or may not buy some of your medical resources. We've talked about corruption. Are we not opening an even bigger door as far as that's concerned? Because to cut out the Competition Commission, which is there for a reason, it has a specific mandate. This for me is very concerning, and perhaps the advocate can give me some information as far as that is concerned. I'm glad that, Siviwe, you mentioned the medical legal claims, and currently the medical legal claims are actually way in excess of in excess of 98 billion. In fact, they are very, very well over 120 billion, just about half of the current budget that is allocated to health. If half of those claims are won, we are looking at 60, 70, 80 billion rands worth of costs. Where is that money going to come from? Because if that money has to come out of the NHI bill, which principally is going to fund health in this country, apart from the predicted deficit of 318 billion, that actually now just leads to 400 billion, and that could just be, just beyond devastating. There is no plans in place, and medical legal claims are not something that you can budget for, and yet this does not appear to have been taken into account. We have already spent, in just the last few months, well over 200 million rand on legal claims to fight some of these issues. And another concern that I have was, and you raised the pilot project. In the last presentation we had with the AG and the states of the department, some NHI grants that were supposed to be there to uplift the health system actually ended up going back to Treasury. That means the money that we had available to uplift our health system wasn't even used, and it was returned. Now, how can we ever hope to have equality when monies that should have been put to very good use were actually returned to the Treasury? And this raises a concern in the NHI as well. I thank you, Chair.
Good morning, Chair. Good morning, colleagues and everyone on the platform. Chair, before I start with my question, I would like to ask you a clarity-seeking question, please, if I may. Chair, now I asked you in a previous meeting that, all the NHI submissions that were handed into Parliament are safe and still, at the Parliament precinct, even after, the fire that took place at the precinct. Chair, you have given me a response at that time, but I see that that response is not minuted adequately in our 15th of February minutes. So I'm asking the clarity-seeking question again, Chair. I want you to note that this is extremely important, is, today is the last day of our NHI submissions and hearings, and it is essential that we know everything is in order Otherwise, we would have to start the whole process again from scratch. So, Chair, if you could just give me a clarity reply on that before I ask my questions, please.
Thank you, Ms. Honorable Ismail. That question was raised by yourself, I think, last week. I had then requested a response from Parliament officials who had given us the assurance that those submissions are all safe, the electronic as well as the written submissions. And so with you asking it again, we could possibly have a reason for asking it again. I would go back once again and ask Mr. Bundy again, but he had given me the assurance that these are all intact and that we'll be able to proceed with this work. Unless you have anything that is contrary to what we've been told, I'm trying to understand why you are raising it.
No, Chair, thank you. I just wanted to be minuted adequately in today's minutes, please. Thank you, Chair. That is sufficient for me. So I will go to my questions, and thank you to the DA panel and of presenters, for a very interesting and thorough presentation. I have a few clarity-seeking questions. I've been covered by my colleague, Honorable Wilson, on the issue of the single purchase model, but I will just ask a further clarity on that. Now, how do we protect the system from price collusion if there's a single purchaser and no room for competitive pricing, as we have clearly seen in the SIU report? Tenders were awarded to companies that overcharged for products or services. Now, most especially, while the country was going through a pandemic, there was major COVID corruption with PPEs. Now, does the panel feel that we will see worse than we saw during the COVID pandemic if the NHI is passed, considering that this bill is huge? My second question, what suggestions can you provide to protect the fund from political interference, considering the corruption and abuse of funds by the previous minister with the Digital Vibe saga? My text question has already been asked, and the litigation question has already been asked. So my next question, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and we understand and know that there will be certain compliance requirements under the NHI for health facilities to actually function. And we know that most of these facilities will not meet the required standard. Does the DA feel that this will further stifle or impact health services to the communities rather than increase quality health services to the country? In addition to this, the Health Ombudsman can't manage to oversee and ensure compliance now. How are they effectively going to manage to ensure compliance under the NHI? My next question, does the DA feel that the referral pathways are labor intensive and could negatively impact timelines and adversely affect the health of patients and even lead to possible death of patients? Now, would you agree that in order to access quality universal healthcare for all, we need to ensure first, that we acquire skilled healthcare workers, increase the amount of healthcare workers in the public healthcare sector, and upgrade our public healthcare facilities in order to actually provide efficient healthcare services to the country? My last question, considering that we are now 27 years into democracy under the present government, and in this 27 years with the funds allocated, nothing constructive was done to fix the dysfunctional health sector. Does the DA contemplate that in a few years in the implementation of the NHI, we will have an efficient and professional healthcare system in our country or not? I thank you, Chair.
Thank you very much. Honorable members, I just want to remind you that we are going to be running way over time. And it is my discretion to make a decision with regards to that. So I will allow as many questions as possible, but we need to be mindful that we also need to receive responses from Ms. Kwahube and Mr. Horn. So let us be mindful of that as we raise our questions. And also for the presenters of the African National Congress, to note our apologies. I realize we're going to be running at least 15 to 30 minutes over time. Thank you. Please continue, Honorable Clerk.
Thank you very much, Chairperson, and thank you to Honourable Warube and Advocate Horn for a very informative presentation. Firstly, how will the supply of healthcare services be increased to match the demand? It is noted that the scheme faces a supply-demand problem, with many public facilities not qualifying to practice in the scheme, and private healthcare practitioners as well as nurses may opt rather to immigrate. Assessments of the NHI trials have revealed some major issues at some state hospitals in the early testing stages for the scheme, while the issue of healthcare workers willing to leave and actively leaving the country ahead of the system is well reported. How do we mitigate the risk, ensuring that we do not face a brain drain of critical skills within the health sector? Number two, would the NHI be far more competent than the current universal healthcare system that is in place? Under the NHI, would the state be able to provide quality healthcare, considering that most of our hospitals do not comply to the 80% standard set by the National Health Department? These standards are completely toothless at the moment, and when requesting inspections on certain facilities, one waits months before outcomes are received, with no corrective measures to remedy these required standards and without any accountability or consequences. Will the establishment of the NHI be in the position to remedy the severe state of decline of our hospitals? The state is currently reliant on private medical aids and the contributions they bring. If private medical aids no longer play a significant role, how will this impact on the implementation of the NHI? Just in terms of criticism towards the DA, often faces that the party is anti-poor. Considering that the bill seeks to provide for equal quality access to healthcare for all South Africans, our stance is clearly against the bill. Can your position not be described as anti-poor? How would we respond to such a criticism? And my last question is, procurement processes were clearly not followed during the pandemic, and as we have seen by the SIU COVID corruption report with 13.3 billion under investigation. It is important to note that the Western Cape was the only province to set up a full tender list. It is also the province with significantly much less lower investigations against this. What has the province done differently? Will centralization of the procurement process solve the flaws in our current system to effectively provide healthcare services? I thank you.
Thank you very much, Honorable Chairperson. Just a few questions from my side. The first one, Chair, is that the presenter has created a perception that the Western Cape is the most well-run and most efficient province. Can the DA then explain, based on the reports that have been received, why there is such a high vaccine wastage compared with the other provinces? Secondly, if, as alluded by the DA, the private is so much more efficient than public, how does the wastage happen in the private sector? My second question, Chair, on COVID corruption, can the DA please remind us if there was any private company involved in this corruption? The third question, the DA has raised the issue of medical malpractice in its presentation. Can the DA let us know if there was any medical malpractice in the private sector, and if they know the figure? Then my next question, Honorable Chairperson, is let me just check my notes. The DA, you have argued that the economic context under which we are operating has changed. Therefore, the National Health Insurance Bill feasibility needs to be re-evaluated. Are you disagreeing with the National Treasury, which expects the GDP to return to pre-pandemic levels as soon as late in this current year, which is 2022? Are you also disagreeing with the Reserve Bank, which expect the GDP to grow by 1.8% in 2023 and 2.0% in 2024? Are you saying that our country will not benefit from a strong global economic growth, less restrictive lockdown regulations as we have them now, and raising the vaccination rates? And then did the DA undertaken its own economic analysis on the GDP growth to arrive at this recommendation of re-evaluating the feasibility of the NHI bill? If so, please share your report with us. Then, Honorable Chairperson, my last question. Honorable Kwahube and your delegation, as you know very well, this committee is very concerned about access to healthcare for all the people of South Africa, especially the poor. Members of this committee are all concerned across all political affiliation. And I want to demonstrate this with the following comments. And I would like you to comment on each of them. The importance and urgent implementation of the NHI was emphasized by the points made by the following members of this committee during the public hearings process and in other meetings of this committee. The first one, the Honorable Thembekwayo and the Honorable Shirwa, have not only brought to Parliament a private member's bill that seeks to have all clinics operate for 24 hours, but they also continuously emphasize to the committee, but the committee unfortunately could not pass this bill because of the lack of resources currently. As Honorable Thembekwayo and Honorable Shirwa are aware, all of us fully agree with them on this matter. And we may hasten to remind them that the NHI bill seeks to do exactly what they are asking. If only they could pass this bill, this dream will be realized. The second one, we heard the Honorable Ziliti Munyai, for instance, sharing a very sad and painful story of himself and his brother having been involved in an accident in December last year. But that sadly, within only he was attended to, and his brother, and this was so because he has medical aid and his brother does not. This is what we have been saying all along, and we really need to implement the national health insurance so that this discrimination never happens again. You yourself know very well that Section 27 of the Constitution of this country is very clear when it says no one may be refused emergency medical treatment. But unfortunately, this inhuman act is happening unabated. Then lastly, but most importantly for this presentation of yours, Honorable Wendy Wilson had lamented that she had gone to a health facility with a helper who she calls my Anna. but unfortunately only Mrs. Wilson was attended to and not a helper. She said that her helper was refused medical care because she had no medical aid. As Honorable Wilson knows very well, the National Health Insurance will not allow this kind of discrimination, as both she and her Anna will receive quality health care equally, regardless of whether they have money or not. What are your response to these three critical points made by members of this committee? Thank you very much, Honorable Chairperson.
Thank you very much, Honorable Chair. I have a few questions. Number one, can the DA explain how it is less burdensome to the health system for patients with minor ailments to seek care with specialists as their primary caregivers rather than be referred from a GP? Second one, please will the DA tell us of any country or any medical aid in South Africa that has no exclusions or no rationing of health services? Number three, the DA is worried it is unclear what services and medications will be covered or excluded under NHI. You will agree with me that healthcare services and delivery mechanism change over time according to the health status of the population and advances in technology. Are you therefore suggesting that these services should be included in the bill? If so, please note that these services will have to be reviewed every 2 to 3 years to keep up with the changes in health status and health technology. If that's this case, does your recommendation mean that once the NHI bill becomes law, the NHI Act needs to be amended in every 2-3 years? If so, how practical is this recommendation? Which country has done such within your own research? Should these services not be in the regulations, which are easier to change? Next question. You are worried SOEs are failing. NHI is not an SOE. It is a public entity. Is the DA aware that most public entities have performed very well in terms of governance and financial management? Did the DA undertake analysis on how public entities are performing? If so, please share your report with us. If it's comparing like with like. The last questions. Just sorry, Honorable Chair, just the last questions. That is little bit more. Last question. Questions. Is DA aware the Western Cape inherited 2 medical schools and 4 health sciences faculties from the previous apartheid dispensation? Does the DA acknowledge that it has no significant international land borders and that it had not inherited homelands? It has by HAR greatest proportion of population on medical aid. How is this an equitable dispensation if compared to the challenges experienced by the rest of the country? Thank you.
Thank you very much, Chairperson. I've got few questions that I want to ask DA. The presentation that they did for us as a portfolio committee. First, Chairperson, my first question. on questioning the bill for not tabulating what will be contained in the comprehensive set of healthcare services to be covered under NHI. Sorry for that. Can the DA care to tell the public which package of the major medical schemes will cover year after next? That will be my first question, Chairperson. My second question, can the DA explain the difference between SOE and the Schedule 3A public entity and how the PMFA applies to each? My other question, Chairperson, to the DA. The DA is of the view that the bill seeks to abolish the private sector providers. Did the presenter miss Chapter 2, Section 8.2, Chapter 8, Section 32, and others where the role of the private sector establishment are covered? The last question, Chairperson, given that the DA is against the provisions of 7.4 of the bill, which makes provision for service providers to limit their scope within the confines of cost-effective services, as shall be determined through health technology assemblies. My question is, why is DA finding it acceptable to provide exorbitant and unnecessarily price healthcare services? Thank you very much, Chairperson. Honorable Kahube, you were part of NHI public hearing. I think the people of South Africa have said it clear that we must implement NHI as the country, because that is the only way that will make us to be equal. And uyayazi ukuthi abantu bakuthi okwangoku iDA ayibakhathalelanga besikhona ezwelitsha abantu bakuthi bebakhala anibaphathi ngendlela right kweza clinic enicinga uba nina niphatha abantu kakuhle. Bakhalile abantu base Western Cape ukuthi impatho enibapha yona ayikho nhle tu, ubukhona ulingqina kulonto ibithethwa ngabantu. Why ngoku xa kufanele ukuthi maku implement NHI ningafuni? Ngoba niyazi ukuthi nina ni benefita kakhulu. Abantu abane medical aid bayakhala bayaphelelwa xa baya kwizibhedlela zenu pha eWestern Cape abafumani incedo olu right. So ndicinga uba mna i-NHI yeyona ndlela efanelekileyo ekokuba iSouth Africa ithathe sikwazi ukuthi silingane singabantu sibe nokufumana intsebenziso ezilinganayo kwezempilo, so that at least wonke umuntu abe equal eSouth Africa. Hayi le eningayifuniyo nina, anifuni because nina niyazi ukuthi nixhamla ngcono kunabanye abantu. Yekani ukucinezela abantu bakwethu, yekani ukucinezela abantu abamnyama. Enkosi sihlalo.
Thank you, Honorable Chair. I just landed at the airport because I'm traveling here for budget speech. If you hear the noise of the plane, it's not out of my making. First and foremost, the DA, Honorable Chairperson, said that they support implementation of the policies aimed at improving healthcare access to South African residents. Yet, the rest of the submission, it's contradictory to the initial statement. How so? My question to the presenter, therefore, is how does the DA believe? How does the DA believe how does the DA believe this improved access to healthcare will be realized? If they can answer that question. I ask this because I don't hear any proposal being made in the DA presentation, if that could be clarified. The DA is against the proposed referral pathways, and they believe they will exclude certain individuals from accessing services covered by the fund. I'm not sure how will this be possible, and also considering that the DA are convinced about the loss of services offered under the National Health Insurance. Why should they, for example, expect everyone to access healthcare at the highest level of care, even if the ailments are minor and can be resolved at the entry-level facilities? I want also to ask this question, Honorable. The DA want the national health, they want universal health coverage without a national health insurance. And I'm repeating again, what are the key alternative proposals the DA want to advance? Because you can't just want universal health coverage in the shell with no content to demonstrative a progressive alternative. Lastly, not even lastly, does the DA believe in laissez-faire philosophy? I'm saying in addition, and I'm saying and the monopoly, the dominance monopoly of the private sector medical aid, which are receiving in the current two-tier statement, in the current two-tier arrangement, which they are receiving almost over 400 billion, which is what? 8% to GDP, right? And service only 16% of the population. And the 84% population is not served. Is this the inequality the DA want to serve? The convention, the international convention is not segregation in the context of Section 27, which I think the presenter don't have to mention a section of the Constitution they don't understand. It will be important that they expand their own understanding or interpretation of those sections, because any country need to adhere to international convention, advanced by the United Nations and World Health Organization. So I think if they read very well the section of the NHI bill that have to be convention, then they will understand the importance of that service, emergency service that need to be provided for the foreigners not to be denied those services. Lastly, Honorable Chair, because you raise issues of time, I want to understand, because how does the board, provincial board in Western Cape under Linde, are employed? Because here in Gauteng, in Tshwane, city of Tshwane, the mayor is involved in the appointment of the board entities of the what? Of the city. Here in Johannesburg, the new mayor, also involved in the appointment of the board, the entity of the Watco. Right? So now, here in Ekurhuleni, again, the new mayor is involved in appointment of the board, but they don't want minister to be involved in such a process. Do they want change to serve their needs? Thank you.
Thank you, Mahlengwa. Honorable Sengwa. I can see on the platform, maybe check if you're not muted. I cannot hear you, Honorable Sengwa. I think for now we will move on to Honorable Siwela. I'll come back to you, Honorable Sengwa.
Thank you, Honorable Chairperson, and greetings to the colleagues on in the platform. Chairperson, I have got one or two questions that I would like to ask the DA presenter. But before the Chair, the DA claims or says in their presentation that the whole NHI bill is myopic. What then I would like to know is in what way is this bill myopic? Is that not an extreme form of expression? Secondly, Chair, can the DA explain how the powers of the provinces to deliver healthcare services were allocated and funded prior to 1994? Was there not a central national health function budget? Did this not work favorably for the minority privileged white population? Is the DA opposed to this benefit accruing to the entire population? Thirdly, can the DA please remind us how many health departments there are now? 10 plus local government, plus 75 medical scheme, but they've just argued that creating one central health budget or fund is not acceptable as it creates fragmentation. Something is missing in this argument. Furthermore, Chair, you have argued that, or the DA have argued that the economic context under which we are operating has changed. Therefore, the NHI bill feasibility needs to be re-evaluated. Are you disagreeing with the National Treasury, which expects the GDP to return to the pre-pandemic levels as soon as late in this current year, 2022? Are you also disagreeing with the Reserve Bank, which expects the GDP to grow by 1.8% in 2023 and 2.0% in 2024? Are you saying that our country will not benefit from a strong global economic growth, less restrictive lockdown regulations as we have them now, and rising vaccination rates? Did the DA undertaken its own econometric analysis on the GDP growth to arrive at this recommendation of re-evaluating the feasibility of the NHI bill? If so, please share your report with us. Then, Chair, as I continue, pardon me for a second. Now, how does the NHI fund described in the bill severely limit options for private practitioners? The bill defines healthcare service provider as a natural or juristic person in the public or private sector providing healthcare services in terms of any law. It treats public and private providers equally. Lastly, Chair, slide 34, in slide 34, please list the countries that conducted feasibility studies prior to reforming their health system to UHC financing models. Because at least as far as government is concerned, feasibility study has been done through our socio-economic impact assessment system for this policy. Thank you, Chair.
Thank you very much, Honorable Slengwa. Honorable Slengwa.
Chair, I see that Honorable Slengwa has posted her questions on the group.
All right, let me have a look quickly. Right, I'm going to read the questions of Honorable Slengwa. She's asking, in your presentation, you have highlighted many constitutional concerns with the proposed bill. Do you think the bill also unjustifiably limits a person's constitutional right to freedom of association, as it effectively forces a person to become a user of the fund to access certain healthcare services, as private healthcare will only be limited to provide complementary healthcare services, which we still don't know what it means? And then what accountability measures would you introduce to strengthen the corruption investigating unit? Have you conducted any feasibility studies on your proposed alternatives to healthcare reform that could be considered? Considering the urgent need for healthcare reform, we do need to find workable solutions to address the inequality in healthcare provision. I just need to make certain if she had reposted this twice, and it looks like it's a repost here. So those are the questions from Honorable Slengwa. Now I would have to ask some questions of my own. And honorable members, we would have realized that we had taken up almost 15 minutes with raising questions. So we'll have to consider what we're going to be doing. But my questions are, the first one is, where does the Constitution guarantee choice? Besides the NHI will not remove all choice. It will only limit entry to the health system specialist level and require care to start at primary care.
Sorry, Chair. We're struggling to hear you a little bit. I think it's your speaker. If you can just repeat that first question, please.
Yeah, my first point is towards your question on people be able to access services at the primary healthcare level and not go directly to the specialist. And you seem to be promoting that people should be going to the specialist directly, which, as long as I've been in medical practice, except for the past 10 years, there's been a movement towards people thinking they should go directly to the medical specialist. And we dare to say that our doctors are very well trained doctors in South Africa, and we should really get this right, that people should know they should start with the medical practice, with the general practitioners in primary care, healthcare, etc., in order for people to access medical care and healthcare.
Chair, I'm so sorry to interrupt the question. We can barely hear you. There's a lot of feedback on your mic.
I'm trying to figure out what that is.
You're fine now.
You can hear me now.
Yeah.
Thank you. So, yes, the second one is the bill says that the fund will investigate complaints. Nowhere does it give policing powers to the fund if the DA not aware of the healthcare sector anti-corruption forum that was established in 2018 and which has resulted in the SIU investigations that the DA has alluded to in the presentation. And then on section 4, subsection 4, where the DA requires, the subsection requires proof of address for registration of the fund. I want to ask you whether you're aware there are more than 15 million people who have already registered as users on the health patient registration system. And the DA seems to believe that ordinary South Africans have been squeezed dry by government taxes and cannot be subjected to yet another tax. Does the DA prefer that thousands of South Africans pay huge voluntary medical scheme contributions and then still have to pay in for the portion of the care that is not covered by the schemes? Or that the majority of South Africans are denied access to the resources of the country because they cannot afford private health care despite them all paying tax through VAT, excise duties, new contributions and subsidies to medical scheme members? What proportion of our GDP spent on health does the DA feel is affordable? Is the spending of the 8.5% of GDP that is currently spent on health in South Africa not palatable to a free market ideology? Is the DA opposed to the redistribution of the 8.5% GDP spending to the entire population instead of making people in those situations? 50% of the total healthcare spending and 60% of the population. And currently, medical aids refuse their clients treatments that are not available in their treatment protocols or formularies, which we're all very much aware of. This is, of course, a limitation, and I get many such telephone calls and requests where people ask me to please intervene and to speak to the medical aids with regards to this. So, this, of course, is a limitation. So, how will the application of such limitation differ from the current status quo, the one that you advise? And the DA believes that the fund should not protect itself from risk. They should pay for everything. Why does the DA hold such a view? Moreover, as the DA by Section 6, 33 and others, where users are given an option to access private sector medical schemes for services not covered by the fund. Those are many, many questions which have been raised with you, and I have raised the challenge with the time limits which we had, which seem to have been thrown out of the window today, maybe out of the door too. I'm going to allow you to answer as many of those questions as possible. We'll have to see and just wing it as we go forward now this morning. Thank you very much. Please continue with your response.
Thank you, Dr. Jacobs. I think perhaps what we can try and do is to hopefully, if that's acceptable with you, to try and get to 11 o'clock. We will try and run through as many of the questions as possible. I will run through some of them overlap, Chair, and they may be covered by what I'm about to say now. And then some of the constitutional concerns Advocate Horn can handle. Is that all right with you? If we can try and take it to 11?
Agreed with me. Thank you. Agreed by me.
All right. Thank you. Thank you very much, Chair. And thank you very much to the members. It's really, really refreshing to see lawmakers really engage with this process. And as Werner had initially said right at the beginning, it feels strange to be on the other side of the committee, but it's good to see that we are really interrogating. And the question that was raised, particularly about the alternative, I'm going to raise shortly. I think it's quite important. It was raised by a number of members about the fact that currently, only 16% of South Africans are covered by medical aid and 84 are not. Essentially, these members arguing about the inequality. I think it would be naive and it would essentially be reductionist to not really see how deeply unequal our health system is. It absolutely is equal. And that's why we are saying that we support universal healthcare, but we're saying the mechanisms through which we get there need to not only be financially viable, but they also need to guarantee that people will actually get the quality care that they need. And so when we talk about equality, it is our desire, and that's why we are here, members. It is our desire to show you where the pitfalls of this legislation are, and where, should there be legislation that is passed by this committee and by extension Parliament, it should look different so that it can address some of the challenges that not only have been raised by the DA, that have been raised by many of the entities who have come to present by you. And so really, I want to then, I'm going to flight quickly a slide that I had skipped due to time constraints. And here, I'm not going to dwell too much, Chair. I'm wondering, am I sharing it? No, sorry. Right. And so I wanted to just okay. I just want to bring your attention to this particular slide in our presentation, because I think it's quite important to realize that not only has the DA seen what are some of the pitfalls of this piece of legislation, but has applied its mind really as to what are some of the alternatives that we can look at. Number one, we do think that there can be a creation of a universal subsidy to every South African citizen, irrespective of whether they are covered by the public or private healthcare systems. Because of course, the current two-tier system, as Honorable Monyai has eloquently put, is something that is of concern. There cannot be one set of a particular standard of care for those who have medical aid and those who do not. And so what we are saying as an alternative is that money should be used to develop a universal subsidy that will be afforded to all South Africans. That then allows them, and this can be developed in the combination of the existing budget allocations, and also what we can see from here is that it would be essentially affordable. But the more important thing here, Chair, is that what it does is that all 60 million South Africans would be able to have a subsidy that they would be able to go to whatever healthcare provider that they want, whichever healthcare provider that they want, whether you have medical aid or not, and you will be able to have access to a basket of services. And then you are able then to say, let us top up. And that's why we haven't raised the issue around the topping up of medical aid schemes as a problem, because we believe that having this subsidy that is afforded to every single South African, regardless of who you are and where you are, will be able to equalize the system. And then services will be at free at the point of service. And this is important because I think it goes to the nub of some of the concerns that the members have raised, that do you have an alternative? Yes, of course, there is an alternative that is not going to bankrupt the country, an alternative that's not going to open this fund to rank corruption like we've seen, but that will be able to equalize at the very least the package of care that everybody can have. But then it doesn't require the centralization of a fund that will essentially be managed by political appointments. And so that is one of the key things in our proposal, which is both in the document that we have submitted to the committee and in the presentation. The second part and the second tenet of our proposal really, Chair, is about the decentralization of services. Our view is that a centralized, convoluted structure of a healthcare service is not efficient. It, in fact, is inefficient. And so if you devolve powers to provinces, and even with those provinces, you can devolve powers to regional structures, what you then have, you make sure that your package of care, or at least your services, are closer to the people, that when they need to hold people accountable, they are able to hold people accountable to the people who actually run the service. And so we don't think that a centralized fund is necessarily going to trickle down to somebody who lives in Alfred Nzo where their clinic doesn't work, because we think that will bring about inefficiencies. So I'm going to quickly run through some of the questions that have been raised, but I thought it was just important to say, we're not just simply saying because it's a buzzword that we support universal healthcare, but there are proposals, there are models which work, which don't require the kind of changes that the National Health Insurance wants to impose, that in fact will get us to a point where all South Africans have access to not just healthcare, but quality healthcare, so that they can be able to have the kind of dignity that has only been afforded to those who have money. And those who don't have money have not been able to access that care. And the reason being is because our public healthcare system has been run poorly. And money is not going to fix that problem. But an overhaul of the system is going to fix that problem. And that's why this bill is not really addressing the nub of the issue. And that's why we say that it's myopic, Honorable Siwela. It's myopic because all that it does is introduce a funding model, says nothing about how do you introduce universal health care. How do you make sure that the system is overhauled, improved, so that you can make sure that people are not traveling more than 5 kilometers away from a primary healthcare facility. All of these things are currently not happening in many parts of the country. So it's myopic in that it is narrow in its focus and doesn't extend to saying, how do we bring about universal healthcare, both from a funding point of view, but also from a healthcare system point of view? Honorable Sheikh talked about people, inequality is a massive problem. Do you have an alternative? And I think that's what I've spoken to now. Honorable Bill Wilson raised a number of issues around the Competition Commission, collusion, and the NHI grant that has been returned. Look, I mean, there's been many issues here, Honorable Wilson, about, as you and all of you would know, that there has been a reduction in the funding of the NHI grant over the years, and simply because I think there has been no movement in terms of being able to fund this kind of proposals that are in the NHI. And so really there are obviously massive concerns to us that Treasury is not in agreement with this committee. And this question has come up quite a number of times. I think it came up with Honorable Sokacha and again with Honorable Siwela about whether or not do we not agree with Treasury and the Reserve Bank. In fact, members, I would argue that we agree with Treasury, that we've got a 380 billion rand deficit. We're spending more servicing debt in this day and age than we are on education and health. And so that is a reality. We can't legislate for a future hope or for a future dream of a GDP that is now growing. You as committee members have to legislate in accordance to the current economic climate that in fact existed even before COVID. It's incumbent on you to pass legislation that will in fact be implementable, because of course then the whole process is null and void. The tax concern, Honorable Wilson, massive concern of ours, because of course, you know, the issue here is that South Africans unemployment is on the rise. The tax base that we are looking at, in fact, is shrinking by the day. We don't think that it is fair. We don't think that it is right to have to impose an additional tax to South Africans when they are already struggling so much. Honorable Ishmael raised an important issue around COVID corruption and the lessons learned there, and how would we propose to take out political interference. We think that a board should not be appointed by a minister, and it will now help Honorable Munyaya understand our proposal. We don't think that a fund of this nature and of this magnitude should be a board that will manage this fund should be appointed by a minister. Colleagues, I'll be hastened to remind you of the fact that we had ministers in this very portfolio. We had MECs, we had mayors across the country, people who were trusted with this public service, who were looting funds during COVID. What you want to do when you legislate, the members of the committee, you want to make sure that you build in accountability mechanisms. Allow Parliament to appoint a board so that they can be able to come up with a criteria which will make sure that you are able to make sure that the people who are there are qualified to do the job, the people that are there are not partisan, the people that are there are not don't owe their allegiance to a political minister, that they owe their allegiance to the people of South Africa and to Parliament. And that would be the proposal, Honorable Ishmael, really, that we would bring in. And Honorable Clark raises an important point, and I think it links in to the point that Honorable Sheikh had made about how do we get to equality. If, there's a notion that if you don't support the NHI bill, that somehow you are anti-poor or you don't support the idea that South Africans who can't afford medical aid should have quality healthcare. In fact, I would argue to the committee that this is the contrary. And I would really hope and I would really plead with you that you don't look at where the proposals are coming from when you are in the legislating making process here, that you look at the process in a very dispassionate way. The reality here is that there are ways to equalize quality access to quality healthcare in the country. But this way in which the NHI proposes won't get us there. Instead, it will get us a bloated system that's open to corruption and won't guarantee people, even the poor, the quality healthcare that we need. This bill misdiagnoses what has gone wrong in healthcare over the years. What has gone wrong is not the fact that the rich are getting quality healthcare because they can afford it. What has gone wrong is that the 84% of South Africans in the country have been let down by a system that has not catered for them. So when you are fixing that, you don't simply say, let the entire 16% become the 84%. What you do, you say, we want 84% of South Africans to also enjoy quality healthcare like those who have been on medical aid and who have been enjoying quality healthcare. You want to bring the country up, but you don't want to bring the country down in a race to the bottom. And that's what we are pleading here with you. And so Honorable Sokacha has asked a number of questions asking about whether there were any malpractice, there's any medical legal claims in the private sector. And I do want to again come in on this point, Honorable Sokacha. Our presentation is not here to come and do a presentation on behalf of the private sector. You have powers as a committee to summon the private sector and ask them about these very medical legal claims. However, what we are saying is that there's a rising cost of medical legal claims within the department that are threatening to bankrupt the sector. And what we are saying is that there are certain things within this bill which will mean that these kind of medical legal claims are going to rise. And it will mean that it will further send the department into the red. We're not here to talk about whether or not the private sector is any better. What we are saying, though, is that the sweet spot exists in the collaboration between the public sector and the private sector. The sweet spot arises when the public sector can rival the private sector in the quality that it provides. It shouldn't matter if Honorable Wilson's Anna goes to Mediclinic or goes to Khayelitsha Hospital. It should all be the same. And that's what we're saying, that go back to the drawing board to make sure that you can make sure that this happens. And as I said, he asked the question about, do we not believe Treasury? I think that, in fact, this committee may not be believing Treasury. Treasury has repeatedly, for the past 2 years, said that we have not actively budgeted for the implementation of NHI. So we plead with you to please, when you legislate, you look at the current economic climate that we are in. And Honorable Sokacha again raised the issue around the EFF's proposals on 24-hour clinic and that we don't want any discrimination. Again, I want to disabuse the members in the committee about the notion that we want to keep a system where only those who have medical aid can have quality health care. What we are saying is that those who don't have medical aid should be able to access the very same care that you can get at a public hospital, and that's within the powers of government. Honorable Harvard asked the question about, will the package of care not be included in the regulations? Of course, I mean, the regulations can be a lot more detailed than the bill itself, but it was important and incumbent on us to point out that currently, as the bill reads, it's very open to interpretation. It is vague in which package of care will be provided. It would have been suitable rather to be able to say, look, if we want to really bring a legislation that is this wide ranging, this is what we would be looking at. This at least are the types of packages of care that people will be able to have. Honorable Gela raised the point of the fact that the Schedule A is a public entity. and is not an SOE. And of course, we've said that this is a public entity, but I do want to read for you a particular section, Honorable Gela, that says, the remaining public entities are classified as Schedule A and Schedule 3A and Schedule 3C entities. These entities are normally extensions of a public entity with the mandate to fulfill a specific economic or social responsibility of government. They rely on government funding and public money, either by means of transfer from the revenue fund or through statutory money. As such, these entities have the least amount of autonomy. What we are simply saying is that the tenets of what has failed in SOEs and the tenets of what will fail in this public entity are similar. They are open to corruption and it is open to public looting. And so, yes, there are differences between the way in which SOEs and Schedule 3A entities are put together. But ultimately, the weaknesses of both of those entities exist in this fund. And that's the point that we make. And you raise an important point, Honorable Gela. Xa uthetha ngento yobana abantu bethu sibavile kwi-public hearings bethetha ngento yobana ii-services abazifumanayo abazonelisa kangaka and therefore bafuna i-NHI. Ndifuna ukuthi kuwe nam ndandikhona ndinabo ubungqina. Abantu abaninzi sasidibene nabo kweza public hearings babephakama besithi ii-clinics asinazo, oonesi asinabo, oogqirha asinabo, sifuna i-improvement kwi-public health system, which is in effect what we are agreeing with. We're saying invest in the system, then roll out UHC so that you can make sure that people don't just have access. Abantu abavele baye ekliniki kuthiwa ekliniki akho mayeza, kuthiwa ekliniki akho zinesi, because abantu abaninzi, Honorable Gela, zange baphakame bathi bafuna i-NHI as the bill. Abantu abaninzi babephakama besithi bafuna iinkonzo eziphucukileyo. Ndiyavumelana nawe into yobana a lot of people have been let down by the system, and that really ingumsebenzi wethu sonke singamalungu eParliament uqinisekisa into yobana abo bantu bazifumana ezo nkonzo. And we're not going to do that if we are obsessed about centralizing power in one fund that does not guarantee into yoba abantu bazazifumana ezo nkonzo bazifunayo. And so really, this is not about our obsession about NHI versus universal healthcare. I'm almost done, Chair, I promise. Honorable Munyai, how do you think quality will be achieved? I mean, I think we've covered it in the alternative, because he did ask about the alternative proposals that we have. And Honorable Munyai, we don't think that the exclusion of foreigners or asylum seekers is consistent with Section 27 of the Constitution. We may have a discussion separate to this one about what that section says in the Constitution. We don't think that that exclusion is in line with global the way in which the globe is headed. And I've spoken extensively about the danger of having a politician appoint this board, particularly because of the size of the fund. I've covered Honorable Sewela's question about myopicness of the bill. Honorable Shengwa, the Honorable Advocate Horn will answer the questions that you were asking with regards to the Constitution. But again, we've spoken extensively about how the committee can make sure that there's greater accountability sewed in. And Honorable Dr. Jacobs, I agree with you. I agree with you extensively when you say we want people to be able to access primary health care and then move up the rank as according to their need of care. I agree with you. However, the problem that I raised here is that in the current state of our health system, where you will have somebody who does not have a primary healthcare facility close to them, or one that is of quality, that provision the provision in that bill will limit and will be a barrier. Because what happens if I only have a regional hospital that is within 5 kilometers, in a 5 kilometer radius as me? And so what we're saying is that we've got to fix what's broken with the system, so that when we do impose provisions like that, then people know that if I only have to go to a clinic and then the clinic has to refer me, I know I'll go to a clinic that has all the things that I need. And of course, the issue around the limitations, Dr. Jacob, the limitations of the package of care. I think the issue here is about the clarity. What will be limited and what would not be? As you have said, I mean, the issue here is that even with medical aids, there's been massive issues, as the healthcare inquiry showed us, that there's massive issues with medical schemes, with overpricing. All of these things are a problem, but it does not mean that when these problems are there, that we should simply make the entire healthcare system have the qualities of these things. The health market inquiry was very clear about what government ought to do in terms of bringing down the collusion of prices within the private medical space. But also at the same time, we think we need clarity on what the package of care will include from this bill. Advocate Horn, if you could perhaps just touch on one or two points that were raised around the laws, particularly the duplication on SAPs and the one issue on the constitutionality and the concerns we have. Thank you.
Yeah, I'm in your hands, but I will try and be very quick and maybe just say to colleagues who have asked questions around my part of the presentation, which maybe will not be answered, I will feel your pain. I'm also a member of a portfolio committee who sometimes are not answered, and it's no disrespect meant. Chair, let me maybe firstly deal with your first question as to where does the Constitution guarantee choice? And I would advise that all members of the committee carefully study Section 7, the very first provision in our Bill of Rights, which enshrines our right to freedom. And then if one looks into the legal definition of freedom, it is sometimes defined exactly in the negative: the absence of constraint in choice, the liberation from restraint, or the power of another. So that would mean that in the very first section of our Bill of Rights, choice by inclusion of the right to freedom is included as one of our rights. You also, Chair, refer to users given the option to access private health care in some provisions of the bill. And therefore, I would think you argue that there is some choice still included. Our view is just, Chair, and you and some others have referred to specific provisions which talks about private health care. The reality is, however, if you read those in context with Section 55A, M, R, T, and W, it's quite clear that both the options to patients going forward, as well as medical practitioners in respect of private practice and accessing private healthcare, will be dependent on the benevolence of one person, and that's the minister. And in our view, that's highly problematic. You also asked about how our criticisms of the investigation unit in light of the fact that it is to investigate complaints. The question is to be asked, what if these complaints in essence really satisfy the definition of a crime? That's the one aspect. We cannot have a situation where given the very tight centralization of decision making in terms of this bill, where for whatever reason crimes are then not reported to the SAPs. That's the one aspect. But the other aspect as well, talking about financial implications, a unit like this will of course bring with it massive financial implications for taxpayers. And we return to our argument to say, but in between the Public Service Commission, the Public Protector, and the SIU, there are already established institutions which are empowered to deal with corruption and these types of complaints. May I maybe also say the Honourable Tsilitsi says that we do not understand Section 27 properly in light of our criticism that asylum seekers will not get the benefits promised to them by the Bill of Rights. I want to say I think we must agree to disagree, but also to say that it would not be proper for this committee to pass a bill and then say yes, maybe the bill we're passing is problematic, but then we still have international convention which will dictate to us as a country what to do in certain circumstances. And then lastly, Chair, in respect of the tagging issue raised by the Honourable Wilson, I don't know whether that's fixable, but what I want to suggest, and others has referred at length to National Treasury, and there seems to be a bit of a difference in opinion in respect of the satisfaction on the part of National Treasury that this bill can be funded in terms of our current economic climate. I would want to suggest that this committee consider engaging National Treasury in inviting them to hear their views both on the tagging issue as well as the affordability issue. It is so that National Treasury, by and large, over the years have been more positive in its outlook than what realized in terms of actual growth rates. And in that sense, I want to end off by saying, even if we are to return to pre-pandemic levels, what the one stark difference that is there, and that which this committee must take into account in terms of the feasibility of this bill ultimately, is our debt levels, which has not returned to pre-pandemic levels. So if the situation pre-pandemic, in the view of this committee, was sufficient in nature to justify implementation, then it remains that even if our GDP and our growth rate improve somewhat, our debt levels are still scarily high. Thank you, Chair.
Thank you very much to both of you for those answers. You are also very welcome to send some written replies should you deem it necessary. We appreciate you coming to do your presentation and also answering these questions to the satisfaction, hopefully, of the members, but we'll be able to hear about that. You could please do a final concluding remark and we will move on to the next presentation.
Just 30 seconds, Chair, just to say thank you very much to the committee, like I said, for engaging with us. We think that this is what lawmaking is about. It is about it's about the competition of ideas. It's about ultimately picking what is going to be the correct course of action for the people of South Africa. And so I think regardless of where political lines are drawn, I think that we are at least united here and in the House about the fact that things need to change. The health system needs to change. Now it just becomes about the nuts and bolts of how we get there. And I have all the faith that the committee will eventually be able to get to that point. And so thank you very much for having us and for allowing us to do this presentation.
Thank you very much. And of course, I agree with you, things need to change. And it needs to change for everybody in South Africa. We need to make sure that all people have access to good quality healthcare in South Africa. And I think this is what the bill is trying to speak to. And as you say, we're going to be going through the nuts and bolts and see which fit and which do not fit, etc. So thank you very much again. Honourable members, let me welcome the Deputy Minister to our platform. He had been on for a while, Dr. Sibongiseni Dlomo. Secondly, let us also note that we had allocated, in my discretion, a lot of time to this presentation, which had just been completed. And I would have to be fair in the next presentation to allow this, the time that is required. Should we go over the needed time, I would also allow that. And that with that said, let me then welcome Dr. Konfi Moloko, who will be doing the presentation on behalf of the African National Congress. If he can please switch his camera on, introduce himself, and also introduce the rest of his team, and go on with the presentation straight after that. Thank you very much.
Good morning, honorable members. The chairperson of the committee, my name is Phoebe Potgieter, and I'm here with Dr. Moloko as well as Dr. Gwen Ramagopa, who will do the presentation on behalf of the African National Congress. Thank you very much for this opportunity, honorable members. In 2016, the African Union, when it adopted its Africa Health Strategic Plan 2016-2030 made the point, and I quote, that in order to create better performing health systems and decrease the African burden of disease, we require the following issues. Firstly, a multi-sectoral collaboration. Secondly, adequate resources. And thirdly, leadership to champion implementation, as well as ensure effective accountability. The public hearings about the National Health Insurance Bill is about ensuring all of the above, to ensure that there's multi-sectoral collaboration, that there's adequate resources, but also that there's leadership to champion and ensure implementation and ensure accountability. The bill is about ensuring that all South Africans have equitable and universal access to healthcare, and our submission will speak to those areas. So if we may be allowed to share the screen, Chairperson.
Yes, you're very welcome.
Okay. Our presentation will be, firstly, we will start off with Dr. Gwen Ramokgopa that will do the introduction. And then we will hand over to Dr. Moloko that will then do the rest of our presentation. And then we will be ready for questions from the honorable members. But once again, thank you very much for this opportunity. Dr. Ramokgopa.
Thank you very much, Ms. Potgieter, and thank you to the chairperson of the Health Portfolio Committee, honorable members of the Portfolio Committee. I also would like to appreciate the presence of those that are online, like ourselves, and acknowledge also the presence of the Deputy Minister of Health. We take this opportunity to make this presentation as augmenting our previous submission, and we want to thank you for allowing us to do this oral presentation. Our presentation would really, briefly take us back in terms of the journey that South Africans have been in towards and making efforts towards ensuring that we join the global civilization that supports health as a human right for every citizen in their country and also in the world. We affirm also the commitment of our president, especially in terms of the manifesto as a mandate of the people of South Africa. And we reaffirm that the ANC reiterates its commitment to putting in place a quality health system of national health care, and that we will expedite the implementation of the national health insurance through finalizing enabling legislation and putting in place the National Health Insurance Fund. We will come to this aspect of transformation of the health system. We must acknowledge that the fund is one of the pillars that are being transformed to give us universal health coverage. All South Africans, as we have committed, must be able to access quality health care based on need and not on their ability to pay or their overall socioeconomic situation. And further, in line with our constitution, that government for its part will honor citizens' commitment by ensuring that resources are well managed and efficiently deployed. And this NHI bill before you, it is, we want to commend government for having processed it up to the level of the bill, and we thank the Portfolio Committee for the work it has done to date to enable South Africans to engage it. The objectives of our submission first, as I've indicated, to reaffirm our full support of the bill before us, and that we ourselves underwent a very extensive consultative process
within the mass democratic movement, within the African National Congress itself, and with society broadly. We will also recommend some amendments to the bill informed by the inputs from our own members, citizens, communities, sectors, and various stakeholders we have consulted and or have made submissions to us as well. We will also want to extend the appreciation, as I've indicated, especially for the portfolio committee having gone to the length and breadth of our country, to rural and urban areas, to informal settlements, and to also ensure that everyone, including those that are in suburbs, make their voices heard. And indeed, we would like to call on South Africans to join hands and also join the people of the world in the march to the realization of universal health coverage. Therefore, Chair, we really want to support this process and also encourage yourselves to do everything possible to ensure that the long-awaited NHI Act becomes a reality. The next few slides, we just take you through the journey of the people of South Africa's aspiration to have universal health coverage. It didn't just start yesterday. As some of the critics say that we are rushing, this has not been a rushed process. From the African claims, actually from around 1928 to date, it's almost 94 years that the South Africans have been trying and trying to ensure that we indeed ensure that health is a human right, that anyone who is ill gain access to quality health. And some of these efforts and initiatives were led at the front by the African National Congress. And we want to appreciate this from our bearers, but we also appreciate the likes of Dr. Henry Klugman, who was a visionary for his time, and many others, Brumbeck and Shisana as well, at the beginning of our democracy, also contributed to this effort. So it has been an effort beyond the ANC, but of the people of South Africa who are progressive. And we also outline here that all these efforts resulted in 2012, all the people of South Africa across party political divides embracing the national health insurance system as part of a journey towards universal health coverage in the National Development Plan 2030, which was adopted in 2012. So it has been a journey. I did refer to the electoral mandate, and here we were very specific when there was a proposal to the people of South Africa, and overwhelmingly they gave us, the sixth administration, the mandate to indeed ensure that the NHI becomes a reality. With respect to government, government processes on the NHI span beyond a decade. If you look at when the Green Paper on the NHI was published for comment, that was around 2011, and not only once, but twice, there was a white paper just to show how involving and participatory and responsive the processes were in consulting the South Africans across all divides, and to make sure that by the time this bill is presented to yourselves, which was in 2019, the voice of South Africans has been indeed included in there, the aspirations, the concerns, and all that. We also want to reiterate our support of the understanding of the National Health Insurance policy and the insurance bill, what the insurance bill intends enacting. Firstly, we believe that this is a fundamental transformation of a fragmented, inefficient, and inequitable healthcare system. and that the NHI Act will integrate the quality health system. We hear many of those that have the fear and the fears which we need to allay, anxious that something will be taken away from some other people who have. But I think we'll acknowledge that the inequalities that are there currently cannot be justified any longer, where almost half of our economy, the resources of health in our economy, only looks after 16% of the population, whereas the other half looks after 80%, and the rest, it is out of pocket. And even those that use the private health system face financial difficulties should they have some of the dreaded diseases going back to the under-resourced public health system. We must also acknowledge, and this Dr. Moloko will go more into detail, we must also acknowledge that the inequalities themselves are also as a result of government inaction, adequate inaction in reforming the financing of the health system. The fund, therefore, is established to purchase healthcare services based on the principles of social solidarity and equity according to health needs and across irrespective of socioeconomic status. And they are aimed, the NHI is also aimed at better access by everyone to quality health services, protection against illnesses, the illness-related financial hardships, and also for promoting efficiencies. We want to really encourage the portfolio committee and parliament in general to view the NHI as a very firm step, a move that moves South Africa closer to universal health coverage. I did indicate that we'll come back to the issue of the financing. We will realize that the transformation of the health system has various legs that all of them need to be addressed. And in terms of the service delivery platforms, I don't want to go back, but because we're not dealing with the performance to date, but we need to reflect that the 25-year review indicated that significant progress had been made in service delivery, which resulted in the improvement of the health of the children, with the child mortality on the decline, maternal mortality on the decline, and life expectancy of South Africans indeed improving. Primary health care has been strengthened in rural and urban areas, covering those that in the past didn't have access to health services. Chairperson, when I was in training and my early years as a medical doctor, there were many children who were dying in our heads of severe malnutrition, what we refer to as kwashiorkor and marasmus. And South Africa actually made a breakthrough. We hardly see these cases anymore. The students of maybe a decade ago in this democratic era qualify without even having seen a single case. Yes, more needs to be done, but we must not throw away, but build on the progress that we have made. We also know that in terms of integration of the health system, we have made some strides. Early in the conceptualization of the NHI, in the piloting processes, the minister also integrated the GPs, primary health care of the private sector and the public sector together. And if anything that we should learn from COVID is that the government was leading society as a whole, public and private sector, for a response. And we worked well together as South Africans. So we need to allay the fears of the consequences of integrating the health system, but more look at the benefits thereof. So this bill focuses mainly on the financing. The health workforce A lot of progress indeed in making sure that we expand the training platform, that we introduce community service, and so forth and so forth. And the health information system, we have an electronic information system currently in the primary healthcare facilities, and indeed working with the Home Affairs. We make sure that children are registered where they are born. These are some of the significant advances we have made. In terms of medical products, vaccines, and technologies, it's not only our clinics that provide medicines, but also private sector has been roped in for chronic medication. And in terms of leadership and governance as well, there has been efforts in almost all areas. So this bill focuses mainly on the financing, the reforms in financing that will accelerate and root the transformation agenda indeed into and move us into the universal health coverage. I did indicate that the NHI places the health of the people at the heart of sustainable development, at the productivity of our society and our economy, and also at the heart of building a caring society, a happy and thriving nation. When I refer to happiness, I also deal with a high burden of stress in our community, of mental illness, and happiness is also used to assess the extent to which a country is investor friendly. And we know that many of our people still have their needs to be addressed to achieve this happiness. However, we're also responding to the global move towards universal health coverage. I'm going to now hand over to Dr. Moloko, who will take us through specific areas that we believe need to be amended. And we believe that these amendments can be done in this process by the Portfolio Committee and Parliament, and that the act that has been delayed for so long need not be delayed any further. Our people have been waiting, and it is now time to deliver NHI. Thank you. Dr. Moloko.
Chairperson of the Portfolio Committee on Health, Dr. Kenneth Jacobs, honorable members of Parliament, and members of the Portfolio Committee. I hope that I'm visible there. Invited guests, ladies and gentlemen, greetings from the African National Congress once more. Let me once again, on behalf of the ANC, express our gratitude for this opportunity to address members of the Portfolio Committee. And on the matters of health as they relate to the National Health Insurance Bill. The ANC appreciates this opportunity. Just to give the context, let me mention that the National Health Bill, which is based on the policy that is enshrined in the white paper on the NHI, represents a substantial policy shift that will necessitate a massive reorganization and unification of the current health system, both public and private sector. It is aimed at transforming the fragmented two-tier health system that comprises of the public and private sectors into a unified health system. It is not a bill that is aimed at reforming the health system. It follows in the footsteps of the 1997 White Paper for the Transformation of the Health System in South Africa. Let me also emphasize the point that the passage of the NHI bill through Parliament will provide government and the masses of our people in South Africa, black and white, rich and poor, not only the poor, with a legal framework that will enable them to attain our people's long-standing demand as expressed through the ages and captured in the body of declarations and programs, as Dr. Ramokgopa has already alluded to. We have definitely walked through this long journey. We have traveled through the long road to equitable health. And so let us use this process of passing the bill through Parliament as the appropriate means of arriving at our destination, which is the NHI Act. Dr. Ramokgopa did touch on the milestones throughout the history of our country. But the most important thing that I would like to remind all of us as we are working on this is that from 1994 to 2007, we have worked on trying to get an equivalent of this, and that was the SHI. And from 2017 to 2012 now, it is 15 years that our people have been waiting. Just to add, we also have to remember that, or to note that in the health sector, we are dealing with a highly concentrated supply and market structures. 3 hospital groups have a combined market share of 83%. And 16 medical aid administrators in the market, 2 account for 76% of the market. The resolutions that had been taken as a foundation of what we are doing were aimed at strengthening the health system. And the ANC supports all the underlying principles based on the NHI policy. The principles that the ANC supports on the funding of the NHI include allocation from general tax revenue, and it also requires progressive real increase in allocations for health. Also that no one eligible will be allowed to opt out of the NHI, and that the contributions will be shared between employer and employees. Now, the ANC affirms these aims and principles of the NHI bill. And those include the equitable access, health is essential for human welfare, economic and social development. Health is a human right and not to be commodified. And right to access to health, social solidarity, healthcare as a public good, affordability, efficiency, effectiveness, and appropriateness. The bill covers critical areas, and those areas that are covered by the bill, the important areas, they are strengthening the national health system. That is the most critical thing, strengthening the national health system. Improving the quality of healthcare, affordability, phased implementation, good governance of the NHI fund, the role and responsibilities of the Minister of Health, institutional arrangements, the role of private medical aid schemes, financial matters, transitional arrangements, and amendment of the relevant laws. We are aware that members of the Portfolio Committee are very familiar with the NHI bill and the definition of the NHI. As we have been working for so long on the bill, we are highlighting these definitions and we are highlighting these points just so that we can be at one in our discussions. The ANC supports the support of the ANC for the specific objectives and principles of the NHI bill. The ANC has consulted widely amongst community sectors, health professionals, youth and elderly, employers, workers, and experts, and makes the following inputs that capture the aspirations of the millions of people. The ANC has also actively participated in parliamentary hearings that have been taking place across the length and breadth of our country. In the bill, the first area that the ANC would like to express its support is the preamble to the bill, as this is aligned to the Constitution of South Africa. It states and mandates that there be redress in the past inequities, that health is a primary right for all citizens, and further states that government or state must ensure progressive realization of citizens to this right. The ANC in chapter 1, which is the purpose to establish and maintain the NHI fund, the ANC supports the point that of mandatory payment system with its principle of mandatory contribution to pay, but according to their ability. This is to ensure social solidarity and sustainability of the NHI fund. The NHI fund established as and serving as a single purchaser and single payer fund, pooling of funds and strategic purchasing from accredited and contracted service providers. The ANC is of the view that the applicability of the Act and the compliance of the NHI Act with the Constitution of South Africa that is represented by the bill itself are supported. The ANC supports clause 3.5 of the bill and believes that health is a non-tradable commodity that must not be subject to the rigor and dictates of the market. It believes in putting the people first and not profits. Therefore, the NHI health services must be exempt from the said Competition Act. In chapter 2, which is access to healthcare services, the ANC supports the population coverage, rights of users, healthcare service coverage and cost coverage as stated in the NHI bill. On clause 4.2, the ANC further proposes that the NHI Act must be explicit about the need for all, especially illegal immigrants, to comply with the provisions of all South Africans' laws, especially the South African Immigration Act. Further, to enhance resources of revenue for the fund and to cover immigrants, the role of multilateral bodies such as the UNHCR to ensure sustainability and affordability of the NHI fund. This must be added to clause 49 of the bill. Just on that clause, as it has been debated very vigorously, we should note also that at the level of government, the National Department of Health and the National Treasury and other related departments have been given the responsibility of making sure that they look at the health services and the provision of those services to various kinds of immigrants and make sure that South Africa is able to contribute its part and all other structures are able to contribute their part. In chapter 3, which is the NHI fund, the ANC supports the proposal on the establishment of the NHI fund as an autonomous public entity, as contained in Schedule 3A of the Public Finance Management Act, and proposal about the functions of the fund and its power. The ANC supports the proposal on the establishment of the board of the NHI fund, its constitution, composition, powers and functions, conduct and disclosures of interest, procedures, remuneration and reinvestment. It further proposes that the board of the NHI fund operates independently and implements rule of good governance. For those that might not be aware, there are structures and institutions in government which, in the pursuance of good governance, make sure that each and every member of the board belongs to the Institute of Directors of Southern Africa, thereby being forced to understand and live the principles of good governance. The ANC recommends that clause 15.3 of the NHI bill and acts be enhanced to direct that the board or its representatives and the minister meet every 6 months to share information as a practical expression of the relationship of the board and the minister, who is the executive authority, and the board, which is the accounting authority. Most boards meet quarterly to do their own business, and this is not what we are referring to here. In chapter 5, the ANC supports proposals of on the CEO of the NHI fund and recommends that the appointment of the CEO be made in line with good governance practices stated in codes of good practice, such as the King-4 report. The board should be appointed by the minister, and the board in turn should appoint the CEO in consultation with the minister. The ANC proposes that clause 21 of the NHI bill, under the relationship of chief executive officer with the minister and the administration, be expressed in clearer terms. Under chapter 6, on the committees to be established by the board, the ANC has studied that chapter and knows and agrees with the proposals about the committees to be established by the board of the NHI fund. Chapter 7, which is on advisory committees to be established. The ANC supports the establishment of board structures and ministerial committees within the principle of technical competency, experience, accountability for performance and transparency, and that an independent body without any conflict of interest or perverse incentive, prices or levels of remuneration for personal health services such as consultation fees, and all healthcare benefits for all categories of health professionals and service providers in the national health system, including those who benefit from the NHI fund. Chapter 8, which is on the general provisions applicable to the operation of the fund. The ANC agrees that with the proposals on the general provision of the applicable to the operation of the fund, and that in the finalization of this chapter in the NHI Act, which must focus on the integration of the private and the public sector, not keeping the private sector and the public sector separate. It must clarify, especially in discussions and enactment mechanisms pertaining to the development and maintenance of the National Health Information System. The role and place or location structurally of the District Management Office, the contracting unit of primary health care. The fund ICT system must be a fund management tool that is linked to the National Health Information System. The ANC proposes that clause 31 of the bill be enhanced by adding the third responsibility to those responsibilities of the minister to 31(1)(b), integrating the annual 5-year plans of the public sector and the private sector. This 5-year integrated country plan, which must integrate the work and the services that are being delivered by the public and the private sector for the national health system, must ensure the successful implementation and maintenance of universal health coverage for all South Africans with the involvement of all the sectors. Still in chapter 8, the ANC fully supports clause 33 of the bill, as it is aimed at reducing fragmentation and creating a single funding pool based on principles of social solidarity and income cross-subsidization. To enhance the intended objectives of clause 33, clause 88(2)(b) must be deleted, as it allows for the duplicative environment that will bypass the objective of establishing the NHI fund as a single purchaser of comprehensive healthcare services. It is very important, especially when we deal with this clause, especially to those who argue for the retention of the current status quo, that over and above strengthening the health system, the NHI bill is aimed at transforming this fragmented system, but also that we should know that this is a phenomenal bill, one of the most important bills before Parliament. The draft law, whose purpose, as we said earlier, is to bring about fundamental transformation and see to it that the national health system is just and equitable. Clause 34 of the bill is supported, as the fund's ICT system must be deployed as a fund management tool as I've already mentioned. Chapter 9, which is on complaints and appeals. The ANC supports the proposals related to complaints and appeals. Chapter 10, which is on financial matters. The ANC regards the NHI bill as a clause 76 bill and not a money bill. It supports the sources of funds as stated in clauses 48 to 51 of the bill. As a point of emphasis, the bill will achieve the pooling of current resources and factor in equity to cover all citizens comprehensively, attain efficiency, and must be held accountable for effectiveness for outputs and outcomes. The ANC proposes that sources of funds be, open quotes, the money currently available in the public and private sector for personal health services, supplemented by money from the fiscus. This will debunk the prevalent myth of extra taxation. The ANC supports the clauses on auditing and annual reports with clarification of the legal framework of the NHI fund and medical aid schemes and the retention of investment of the funding allocations that are made to the NHI fund at the end of every financial year. Chapter 11, which deals with the ANC supports proposals on the repeal and amendment of legislation affected by the Act as reflected in clause 58 of the bill. It hereby calls upon those charged with the responsibility of this task of amending relevant legislation to work diligently to avoid delays once the NHI Act is passed. On the Memorandum of Objects, the ANC noted matters addressed in the Memorandum of Objects of the National Health Insurance Bill 2019, including compliance with parliamentary processes. The ANC concurs, as we emphasize, that the bill be tagged as Section 76 bill. The ANC has noted concerns raised by stakeholders, the general public, current owners, members, and employees of medical aid schemes, service providers, and many others, including the medical aid industry, during the media and during the consultations and also in the media. Of note is that very few of these concerns are about the translation of the NHI bill into the Act, but that most of these concerns relate to the current realities of services that are delivered by both the private and the public sector. This includes infrastructure, human resources, services, and customer experiences, which are good and bad in both sectors. While still on this point, let me also mention that the ANC has noted that concerns, for example, of brain drain might be there, but those are some of the issues that are in human resources, which in the last many years, the country has been able to deal with. The ANC outside and inside of government continue to attend to these concerns in line with its mandate and decisions of the 2019 Presidential Health Summit and Compact. The ANC has learned from the current COVID-19 local epidemic, and of critical importance is that there are benefits and costs to the health sector. There are costs and benefits to the health sector in its intersectoral and intra-sectoral collaboration. Every action has got costs and benefits. Some well-intended programs that were designed to promote access to COVID-19 testing resulted in continued marginalization of the poor and the disadvantaged. The lack of vigilance by both the public and the private sector has resulted in the introduction, sometimes randomly, of policy changes into the funding and delivery of health services, which might have adverse effects on the implementation of the NHI. On the recommendations, the overall recommendation that the ANC is putting in front of this August body is that the Portfolio Committee and Parliament note that the primary objective of the NHI and the NHI bill is to strengthen the South African national health system through an appropriate health funding mechanism that will require changes and transformation, especially the unification of the public and private sector. Portfolio Committee and Parliament should know the contents of the submission that we did in 2019 and the presentation that we are doing now, especially its understanding of the bill as a draft NHI Act, aimed at providing the necessary framework for the establishment of the NHI fund and the implementation of the NHI. Also note the response given to concerns of representatives of various sectors of the South African populace. Note detailed recommendations that the ANC is tabling to the Parliamentary Portfolio Committee to expedite the passage of the bill through the National Assembly, through Parliament, with a view to establishment of a people-centered NHI fund, gradual and phased implementation, and full coverage of the entire South African citizenry, black and white, rich and poor, with the aim of attaining universal health coverage and the National Development Plan, Vision 2030, the Dictates of African Agenda 2063, and the Sustainable Development Goals. The ANC further recommends that Portfolio Committee and Parliament approve the NHI bill with minor amendments as a transformation process that reaffirms health as a human right for all citizens and as a process to ensure the progressive access to rights by many who do not have access to good quality health services without the risk of facing financial hardships. That it approves the NHI bill as a reaffirmation of health playing a critical role to improving the capabilities of the people of South Africa, their productivity and happiness. Approves the National Health Insurance Bill as a sure enabler to attaining universal health coverage, as envisaged in the National Development Plan, African Agenda, and the Sustainable Development Goal. And also note that the ANC believes that Parliament can give hope to South Africa, that democracy can indeed continue to work for the well-being of all citizens. And that can be done if we expedite the passage through Parliament of the National Health Bill into a legal framework called the National Health Act. Just to expound on what Dr. Ramokgopa had said earlier on, the recommended NHI funding model that the ANC puts in front of this portfolio committee is the dominant public funding model. If one looks at the private funding model, which is the one that is operational in the United States of America, where the market is the key player, it is the worst model, according to various research findings. The model that has been proposed by a number of people and institutions, which is called the blended funding model, which is a multiple public and private funders and insurers and private and public service providers, amounts to advocating the continuation of the current status quo. Many people who appeared in the hearings have lauded Canada and the UK as the best models. And we are not saying that we have got to adopt their model, but that South Africa must construct its own unique model that is being proposed and that is being tabled through the NHI bill. It is very unfortunate that the best health care model, which gives universal and free healthcare services for all, is found in Cuba. And unfortunately, that is beyond the reach of South Africa at this point in time. I will at this point hand over to Dr. Ramokopa to conclude. Thank you very much.
Thank you very much, Honorable Chair, honorable members of the portfolio committees. As we conclude, I would like to refer you to the submission that we made in 2019, and that this presentation augments that submission. We did say that the ANC is committed to executing its mandate in implementing the NHI and universal health coverage financing with the agency. We also said that it also believes that we believe that health is not a commodity, but a human right. That the view is in line with what Onurian Bevan, the UK Minister of Health, who between 1945 and 1951 said, and I quote, open quote, "Illness is neither an indulgence for which people have to pay, nor an offense for which they should be penalized, but a misfortune of cost of which be shared by community, and that no society can legitimately call itself civilized if a sick person is denied medical aid because of lack of means. Medical aid meaning that they help, medical help because of lack of means. We should be inspired. I've heard lots of concerns about the issues of resources. We should be inspired by the United Kingdom as they introduced their universal health coverage in the midst of a great economic difficult period post-World War. But theirs was a commitment to make it work. It is more like us as South Africans when we met together, when we decided that we will make South Africa work. There are still disparities, but we can make South Africa work. Indeed, there are benefits that to individuals that we are sharing with you. I will not go into details, but there will be shorter queues, shorter waiting times. They will be able to share the resources to have cleaner hospitals, no medicine stockouts, good quality food and linen, caring and courteous staff, as the resources of the country are shared to equitably for health workers to share the burden as well. It is important that we say this to build on the progress made. Already the Ideal Clinics program of improving quality in the public health system is taking root. There are also benefits for employers and also labor who would have a much better health status for individuals' capacity to work and also for their productivity and so forth. Going this route also would benefit our economy and must be central to economic recovery and reconstruction, including post-COVID-19 pandemic. And we've also seen that working together, we conquered HIV/AIDS, and working together, we are conquering the COVID pandemic. Already, the president has established a health compact at the government level, and part of that was to oversee and to make contributions, which have been done by many of the participants in advancing this national health bill and enacting it into law. Inspired by our erstwhile president of the African National Congress, Chief Albert John Luthuli, who said, I quote, "I believe that here in South Africa, with all our diversities of color and race, we will show the world a new pattern of democracy. There is a challenge for us to set a new example for all. Let us not sidestep this task. We implore all of South Africa not to sidestep this task of equity in health. And all these presentations we're making, having ourselves been encouraged by the multitudes of contributions made so far. And we're saying, let us put the lives of South Africans first, as health comes first. I thank you.
Thank you very much, Dr. Gwen Ramagopa, Ms. Phoebe Potgieter, and Dr. Konfi Moloko for your presentations. It is much appreciated. And we look forward to receiving some questions by the members. And if we'll be able to answer all of those questions as we proceed with this meeting. The following members would like to raise questions with you. It's Honorables Wilson, Clark, Hlengwa, Ismail, Zuela, Sukacha, Gela, Harvard, Munyai. I'm going to repeat the order. Honorables Wilson, Clark, Hlengwa, Ismail, Zuela, Sukacha, Gela, Harvard, Munyai, and then obviously also myself. You may continue in that order, honorable members. Thank you.
Thank you, Chairperson, and thank you to the ANC for the presentation. There's a couple of matters I'd like to raise. The first one being, in one of your slides, it's a quote, government for its part will honour citizens by ensuring that resources are well managed. Well, according to the FFC, the Financial Fiscal Commission, and the AG in recent reports, that was the single biggest failure of every department in the Department of Health. There was no management. The biggest collapse in the health system was as a result of mismanagement, and we won't even begin to start on the corruption that was recently unveiled by the SIU. Secondly, if the presenters will tell me, when people go to public health systems, to either clinics or public hospitals, depending on what is closest to them, what exactly are they paying? Will you give us an indication of what their out-of-pocket costs are at those facilities? Because our understanding is that they are actually treated there for free. I wanted to deal particularly with taking money from medical aid or the private sector to boost the NHI. There's a common English saying that you can't rob Peter to pay Paul. And if you do that, one or other is going to suffer. If you are going to rob Peter to pay Paul, Peter will suffer. There's no point in taking money from one or denying one sector of the health facilities in order to bolster the other, because the second one will collapse. And during COVID, it was proved that without the private sector, that the public sector would not have coped at all. I am a bit concerned that you are still promoting the fact that robbing Peter to pay Paul is an advantage, number one, and two, obviously, one questions the constitutionality. I'm a little bit concerned about the downplaying of malnutrition that was brought up in this presentation. In a 2021 UNICEF presentation, and it was the world, and I'm dealing particularly with the World Health Assembly, South Africa would have 1.7 million stunted children in 2025, which is twice as high as the 900,000 children, which was the target. 1/3 of children in hospitals' deaths are as a result of malnutrition or diseases related to them. 27% of children are stunted. They will never meet their full growth potential. Most of these children are born underweight on the date of their birth. This is because mothers are not healthy and getting sufficient nutrition to support pregnancies and babies. Now, that is a poverty issue, and we understand the extent of poverty in this country. But in 80% of those cases, those mothers do not have reasonable access to health care. They've got to go miles to get to a local clinic. They don't have the fuel. When they get there, they have to sit for hours under very trying situations. How exactly do you think the NHI is going to change that? If there's no access, there's no access. And if we do not address this very, very quickly, we are going to have a generation of children who cannot meet their full potential, which is going to have a severe economic impact on this country. So I think while malnutrition may have improved, to say that nobody sees malnutrition or stunted children today, I think is a little bit misleading. I need to catch a bus, Chair, so I'll make this last one brief. We're sitting at over 120 billion rand of medical health claims in this country at the moment. If even half of those are won in court, we are going to sit with a bill for 60 billion rand that needs to be paid out. That is not including what already needs to be paid out and what was granted in recent court cases. How exactly, if we are going to take that kind of money out of the NHI, does one propose that the NHI will cope? Treasury has already advised that in our current economic climate, NHI is quite simply not affordable. I thank you, Chair.
Honorable Clerk.
Thank you, Chairperson. My first question, and I've got many questions, but I've cut them down because I am sensitive that we are on a time restriction here. So how will government deal with the systemic corruption and lack of will to end it? Will the NHI not become yet another no help intended plan and a cash cow for more corruption? Sorry. Considering this country's loss of 1.5 trillion rand to corruption during 2014-2019 alone. The recent looting of COVID relief fund shows that 1 out of every 2 rand was stolen, while 62% of contracts were found to be irregular. How will the NHI mitigate this systemic behavior? It has been noted that the current costs of healthcare in South Africa is over 450 billion based on both public and private healthcare spending. The true universal health cost could at least amount to that. Originally estimations for the cost of the scheme were put at 256 billion rand a year. However, it is now up to the National Treasury to determine the true costs. For now, for this is unknown. The question is, how will the NHI be financed? While the bill has earmarked payroll and other taxes to be levied in time, it would be on an already overburdened tax base. Beyond the broad plan, there is no specifics where these taxes will come from and how big they will be. The question remains, what will be covered? Do we fund a model which is outcome-based? Will this will only be over time? For now, all we know is that the coverage is to be bureaucratically decided at some point. And I just want to mention an issue that was raised when the DA did their presentation about the GDP growth going forward after pandemic. So about 9% of the GDP is currently spent on healthcare in South Africa, which is in line with the global average. South Africa already spends a lot more than comparative emerging markets on healthcare as percentage of GDP. But we aren't getting value for money because the state's inefficiency and major corruption causes that for us. Our spending as percentage of GDP is on par with countries like Italy, Iceland, and Slovenia, but we get worse outcomes because the public sector wastes money and has a severe corruption problem. I just want to get to the next question because I don't want to ask all of them. In slide 28, there's a mention that the board operates independently and implements rules of good governance. Can you please elaborate on what you mean by good governance? And in your presentation, there was a mention that the board members belong to the Institution of Boards of South Africa. You know, just a question. I mean, do Mnyeni belong to the same institution? And we just see what happened there during the issues with SAA, and you know, because she was a political appointee, and we really have to guard against that kind of process going forward. Then some criticism, the NHI bill for being driven by ideology and greed rather than sound research and evidence-based policy making. How would you respond to these critiques? And in slide 12, the presentation makes a sweeping statement that NHI benefits will be comprehensive and in line with individual needs for healthcare without risk of financial hardship. Can you please elaborate on this? What is included and excluded in the comprehensive cover? How can you guarantee it won't lead to financial hardship? I thank you, Chairperson.
Honorable Sengwa. Honorable Slengwa. I will move on to Honorable Ismail. Honorable Sengwa, if you can hear me, you can post. Oh, there you are. Honorable Sengwa is next.
Yes. Thank you, Chairperson. Let me welcome the presentation from ANC. I have a couple of questions. One, what financial feasibility studies have been taken to justify the proposal? Why has no such financial feasibility studies with reference to latest economic indicators been made available for the public to view, consider taking into account to scale off the proposal? What alternative to the NHI fund were considered by the governing party to strengthen the universal access to health care? Lastly, many stakeholders have pointed out critical constitutional concern with the proposal bill. Is it your view that this bill is its current format is constitutionally compliant and will not unjustified infringe on the constitutional rights of the people of South Africa? I thank you.
Good afternoon, and thank you to the ANC for the presentation. I just have a few questions. Now, you stated in your presentation that the ANC were in attendance at public hearings and have listened to the people and the thoughts of the people. Now, most of our public reps from all parties were present as much as possible. I want to highlight that many people that attended these hearings highlighted the major lack of service delivery from the public healthcare sector. Examples are lack of an efficient EMS service, shortage of staff at facilities, bad state of infrastructure at our public healthcare facilities, the long lines that they have to wait before they can get any service. And most actually stated and recommended that the present infrastructure needed to be attended to first before we can even think of the NHI. Now, further to that, at the public hearings, we also had doctors, healthcare workers that also had something to say. And doctors stated that while they are totally in agreement with universal healthcare, they would not want to practice in an environment of a non-efficient healthcare sector, as this would not allow them to work under the Hippocratic oath they take. Considering all this, do the ANC then not think we should address the current shortcomings, such as critical skills required, as stated by both DENOSA and the Hospital Association of South Africa, so that we can have sufficient critical skills and theatre nurses before the implementation of the NHI, so that we can ensure effective service delivery to the country? My second question, at most of the public hearings, the issues raised was the corruption in government and the abuse of state funds. We know the NHI bill is looking at billions of rands. Now, taking this into consideration, in conjunction with the COVID corruption and SIU investigations, as well as the digital vibes saga, would you then not agree and recommend parliamentary oversight to improve the accountability and legitimacy of the board, rather than a minister appointing the board, as we've already seen a huge dilemma of corruption with the previous Minister of Health? In your opinion, as the ANC, has the department adequately planned for the NHI, taking into consideration that the pilot projects were not an effective measuring tool for the establishment of the NHI? Would you not then recommend that we start this process again with effective pilot projects, measurements in place, so that we can ensure that the proper feasibility studies are done? I'm also going to be cutting off some of my questions, Chair, just to ensure that we have enough time. Now, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and the fact that these facilities need to reach certain compliance requirements under the NHI, and obviously the basic starting point is primary healthcare, and that would be also the clinics. Now, we know that all our public health facilities are not up to standard, and that most of these public facilities will not be able to operate under the NHI. Won't this impact on service delivery and equal access to quality health services, which is the intention of the bill? Now, most presenters highlighted that the referral pathways are labor intensive and could negatively impact timelines and adversely affect the health of patients. I'm talking about our NHI submissions. Would the ANC then agree with this? If not, please specify or explain your reasons for non-agreement. When I'm looking at the referral pathways, I'm looking at people with rare disease and disabilities, and most especially. My last question. Considering, that we are now 27 years into democracy, and I state this clearly, and I'm saying it again, I've said it in the DA presentation today. Considering that we are now 27 years in a democracy under the present government, and in this 27 years, nothing constructive was done to fix the dysfunctional, if I may use the word, healthcare sector. How does the ANC contemplate that in a few years in the implementation of the NHI, we will actually have an efficient and professional healthcare system in our country? You talk about governance structures, and these are all in place. Now, how effective would you say the present governance structure is operating under, considering that we have so many SIU investigations and PPE corruption that the country has seen with the COVID pandemic, where really services and monies for the people were supposed to be spent on the people? Thank you, Chair.
Chairperson, thank you. And once again, greetings to the colleagues. And let me also welcome the presentation by the ANC. And it is heartening to know that the ANC support the NHI bill. I've got 2 or 3 questions to ask. One, there have been complaints that the bill is irrational. How does the ANC respond to these allegations? Secondly, some organizations have complained that the bill usurps the role and power of provinces. Has the ANC engaged with provinces in which it is governing? And what is the position of these provinces? Lastly, in slide 10, you have proposed that the relationship between the minister and the administration of the fund must be further clarified. What is the firm proposal that the ANC is making in respect of this? Thank you.
Honorable Sukacha.
Very much, Chairperson. Let me also thank the team from the ANC, Comrade Phoebe, Comrade Confi, and Comrade Gwen, for a wonderful presentation. You know, I was listening and it was just music to my ears. Thank you very much, comrades, for that presentation. And I think I heard Comrade Gwen clearly when she said they went out as the ANC and have an extensive consultation process. And that clearly indicates that what they've given us here and presented are actually the views of our masses. Thank you very much for that presentation. Just a few questions from my side. The first one, the ANC asserts that they support the NHI bill as a Section 76 bill. My question to you is, what is the basis of this support? Is the ANC not of the view that the NHI bill should be tagged as a money bill and under the authority of the National Treasury and the Ministry of Finance? And my second question, Honorable Chairperson, in slide 23, the ANC have indicated their support for a single funding pool and a single purchaser of comprehensive healthcare services. What is the view of the ANC of the medical schemes administrators playing an intermediary role such as the role they play in the current medical scheme environment? Thank you very much, Chairperson.
Thank you very much, Chairperson. Let me also welcome the presentation from the ANC and also appreciate the support for the NHI. ANC is the leader of the society, and they know the NHI is the right thing to implement in South Africa. Chairperson, I've got two questions that I want to ask the ANC. My first question, what level of GDP spending on the health does the ANC believe is the reasonable target to aim for? The second one, governance is an issue that has been raised in several presentations. Does the ANC not think that a cabinet committee may be a better option to appoint the NHI board and then leave it to the board to appoint the CEO and executives? Thank you very much for the presentation. Thank you, comrades.
Thank you very much, Honorable Chair. Just one question. Can the ANC clarify further why in slide 24 says that the issue of extra taxation is made? Thank you.
Thank you very much, Honorable Chair. May I please proceed?
You may, Honorable Munya.
Firstly, let me welcome this very powerful presentation from the African National Congress, which was very comprehensive and clarified all details of the NHI bill that we know it to be, But let me start with the 5 questions. But some question, Honorable Chair. In slide 5, the African National Congress have indicated the constitutionality of the NHI bill. Some presenters have complained that the bill is infringing on the human rights of the citizen of South Africa, such as their right freedom of choice, and the bill is regressive. To a degree, they argued that the bill will not pass the constitutional muster. What is the position of the ANC on this allegation that has been presented? In slide 17, the African National Congress presentation, you have indicated that to address the burden imposed on illegal and undocumented immigrants on the health system, the role of multilateral structures such as the UNHCR and the African Renaissance Fund to support funding for healthcare systems. Can the ANC please clarify further how this can be implemented? My other question, comment or the question, in the presentation of the ANC, and they clarified this issue of the 2-tier systems and how it continued to perpetuate the inequality within South Africa, and making sure that 84% of the population remains with no access to money. Can the ANC expand in that manner? Lastly, Honorable Chair, there's been an issue that has been raised by others, not necessarily by the ANC, that the issue of the wanting to challenge the powers of the ministers from Gauteng. Here in Gauteng, the mayor of the DA then Tshwane appoint the board. The mayor of the DA in Johannesburg do the same. And also in Cape Town, the so-called ministers, who is supposed to be MEC, they also get involved in the appointment of the board, but the board will be independent and do their own work. Why do you think? Why the ANC should think that these issues, of good governance, should remain as they propose? Because we think for you to change for you to change the role of the minister in the executive, as enshrined in the Constitution, you need a constitutional reform. What is the view of the ANC? Lastly, I must say, Honorable Chair, the ANC, what is the view of the ANC by some organization that comes with the myth that this bill there will be no money, yet all the policies are funded from the general taxation? If the ANC can clarify.
Thank you very much, honorable members. I will now also raise a few questions to the presenters of the African National Congress. My first point speaks to a possible contradiction and what your view is on that contradiction that has been raised about National Treasury and the Minister of Finance, who do not support the implementation of the NHI. And the question is whether it's possible that a department and a ministry in government can make such assertions, such as that the country cannot afford to commence NHI as the desired form of the health reform. And the second point speaks to your recommendation that the ministers should regularly meet to oversee the proceedings of the NHI fund. Is this proposal aimed at enhancing governance within the fund, or is it based on some of the lessons cited as having been learned when the country dealt with COVID? And I ask this clarity regarding the mandate of the minister, and thinking that maybe some clarification is needed from your side if the proposal made by the presenter is to be considered. And my last point to you speaks about the statement that was made that some programs are designed to promote access to testing, or rather some programs which had been designed to promote access to testing has resulted in or have resulted in marginalization of the poor and the disadvantaged. So what lessons must the NHI then learn from this experience, and us as the portfolio committee to take home as take-home messages? Thank you very much. You're very welcome to reply to all of these questions, and we look forward to your replies. Thank you. Dr. Ramakgopa, or Ms. Potgieter, or Dr. Moloko?
Okay. Good afternoon once again. I hope that you can now you are now able to hear us.
Yes, we can. Please proceed.
Yeah, I will start with answers to a few questions, and then Dr. Ramakgopa will follow. And if there are any questions that maybe we have not been able to cover, we will submit those in writing. Before even answering, let me just indicate here that when Michelle May Harvard asked the question, we did not get the question. So it will be highly appreciated if we can get that question. Starting with the last questions that the chairperson had asked about the proposal that the minister should regularly meet with the fund. This is not a proposal where we are saying that the minister must meet with the fund to manage the fund. But it is a proposal that is saying it is very good practice, even in terms of governance, that the shareholder regularly meets, not for the sake of negotiations, but to get briefings as to what is it that the fund is doing, and also the health of the fund, and also to be able to exchange ideas that will make sure that the minister is at all times, even if the board is independent and it is able to carry out its activities, that the minister all the time stays au fait with what is it that is happening with the fund. There are good local, what I would call local good practices, and also international good practices, where you find that the minister is able to meet with a particular board, and the deputy minister is able to meet with a particular board regularly, and that strengthens both the board, the institution, and also strengthen the oversight role. You did mention, you did ask a question about some of the lessons, and you specifically were asking about the programs that during the time of COVID, some of them were very well meant, but at the same time, it was found that manner in which they were being run, there were people, especially the poor, who ended up being disadvantaged. I will be very specific on this one and say that we had a very good fund which promoted access to testing by people who could not be able to go to big centers and also to go to the big hospitals. But in many instances, the testing sites were found in urban, in very elite shopping malls. And the condition of testing at times would be that they would only test people who are coming in on a drive-in basis. You don't get out of the car and you get tested and you drive away. Now, the bulk of the people that are coming from townships and squatter camps do not have cars, and many of those people were turned back. So some of those things we would, if we are talking about universal access to services by everybody, it means that working together as the public sector and the private sector, we have to be able to reach everybody, including the poor, the poorest of the poor. There was a question that was asked about the constitutionality of the bill. The ANC of the view that the NHI bill will be able to pass the constitutional muster. On the issues of human rights and the constitutionality, it is mentioned that when we are looking at constitutionality, we must be looking at the equality, we must be looking at dignity, we must be looking at the right to life, the right to health care, and all this that, and right to social security, and all this that we are mentioning. The bill does make a provision that this not be evaluated. It is interesting that the question was also asked in the context of regressive rights and progressive rights. But unfortunately, it sounded to me like when we are talking about the NHI being a funding mechanism that will make it possible for everybody to be able to get certain rights, the argument was that the status quo must be left the way it is because it will compromise those that already have the rights. I'm not very. I do not think that it is correct to say that the bill itself is unconstitutional because it in any way erodes those. It says that access to health will be equal and there will be equity for everybody. In South Africa, we talk about black and white, and we also talk about rich and poor. So instead of having a situation like we are having today, where 87% of the budget services a very small percentage of the population, and the bulk of the population gets a very meager budget, and as a result, they are not able to get what you get in a private hospital as what you get in a public hospital. The NHI will make sure that that equity is struck, and it is constitutional on that one. There is also, when we talk about constitutionality, people were talking about whether it will pass the constitutional muster as it applies to universality and the rights of immigrants. The submission, the submission that the ANC has made, it is very clear that it advocates that the laws of this country have got to be applied and be applied correctly. And it even emphasizes that everything has got to be done within the Constitution and also be done within the law, especially the provisions of the South African Immigration Act. We have to remember that anyone who is in South Africa, including the illegal immigrants, they are covered when it comes to emergency services, when it comes to services for notifiable diseases, and all children of such immigrants and also the people who are applying for asylum are entitled to basic health care services. Now, in the same breath, the ANC has put it that we have to look at the resources that are available through multilateral bodies, through the African Renaissance Fund, and also through the UNHCR, and make sure that those resources that are being made available to other countries to do exactly what we want to do, we have to be able to access that. When we talk about constitutionality, we also refer to whether we can say that public participation was sufficient and consultations were clear. On that point, the bill passes it with flying colors. The issue of affordability, it has been stated very clearly that the current resources that are available in the private and in the public sector, which are carrying the health system, is the first source of funds. And that additional allocations will be made where necessary. I have not heard anybody in the very recent past talking about this, but if we were to look at the fact that currently we have medical aids, private medical aids, the closed one and the open ones, where only a small percentage of the workforce is making contributions. If the NHI bill says that contribution must be made by all, and no one who is in a position to contribute will be exempted from contributing. And we know, and it also says that the contribution will come from the employees and also the employers. What it really means is that we must be able to sit down and quantify that. And we will see that the source of funds will be adequate and the NHI will be affordable. Of course, there will still be some more work that would be done. So the role of provinces, the constitutional structures and the governance of the fund, all those are covered by the NHI bill. And this is one of the reasons why we are very convinced as the ANC that the bill is constitutional. Just to add one small thing, when the bill, when the policy is made and also the bill is prepared for submission to Parliament, it is imperative, it is in fact a question of must, that cabinet must be favored with all the reasons and proof that the policy and the bill complies with the Constitution, and that we can say that it proves the constitutionality of the bill. I will stop here, and Dr. Ramakgopa will come in, and if there are still other questions, we might still have to come back. Thank you.
Thank you very much, Honorable Chair and Honorable members. Can I please, can I welcome the questions and also the appreciations of our submission. If maybe I should start with a correction for the Honorable Member Wilson. She indicates that I said there is no malnutrition. That's not what I said. I said severe malnutrition. And I also mentioned kwashiorkor and marasmus. I acknowledge that we still have a way to go in terms of dealing with the, the issues of stunting, which is a major challenge for our children, and other malnutrition aspects. However, also in dealing with malnutrition, it is this democratic government that has also instituted making sure that there is fortification, putting nutrition in stable foods to also ensure that mothers and also our workers and children, as they eat the stable foods, there is also fortification with nutritious elements like vitamins and all that. And this relates to, for instance, the mealie meal and that. So the efforts have been there, the results are there, but more still needs to be done. And that's what we call social determinants of health, and the economy and the inequities in our country still put our children much more vulnerable. We haven't arrived as yet. The other issue in terms of medical aid expenditure as an indicator of the cost of healthcare, I think this is not a correct way of looking at it, because in a number of cases, the same healthcare service that you get reasonably in the public sector is unaffordable in the private sector. And that is why even today, when the medical aid or own resources for those that pay out of pocket are already exhausted, every South African is entitled to be serviced by the public health system. Having been in the public health system, we have received many of our, especially middle strata, whose medical aid benefits get exhausted as they are in ICU or as they are undergoing cancer treatment. And the public health system had to expand continuously to ensure that every South African does access services. And the expenditure in the private sector currently as is, and also as alluded by the Competitions Commission, is not and cannot be a proxy, because it is excessively expensive. And that is why even with the public health measures like immunization for children, like vaccination now with COVID, access to the antiretrovirals, government has to plan for all South Africans, just in case the private health sector fails them. So in a way, government has always been planning for everyone, regardless of socioeconomic status, and government has provided everyone regardless. In one of my consultations, the issue of out-of-pocket, one of my consultations at one of the public hospitals, because I didn't have a medical aid, I had to pay 5,000 rands for admission over three nights. So out-of-pocket is extremely expensive for an ordinary South African. And that is why the principle of the health care being free at the point of care is important as such. Indeed, the issue of access is important, but I think it should be noted that regardless even of provincial capacities, national government has invested in a rollout of a clinic program, building program, and also resourcing it with competent nurses, and we've also included doctors in the larger clinics. And I can attest, I can take members to clinics that are compliant with ideal clinic standards. Many are making efforts. Many of our health managers, our health workers are making efforts, and there is improvement in a number of public health services. The state-of-the-art hospitals that have been built, I think of note, institutions like Steve Biko has been built in this democratic era with the support of National. Kayelicha, state-of-the-art for that community, has been built with a huge investment from national government. Germiston, the Betha Klowa state-of-the-art facility have been built in this era. But this is not adequate, and that is why transformation can't be slowed. It needs to be fast-tracked. Before I left as the MEC for Health, had already begun engagement with some of the private hospitals to utilize their spare capacities to reduce the waiting lists for in the public sector. So initiatives are already there to collaborate for the best interest of our people, of every South African and all the people in South Africa. Honorable Member Clark, indeed, many of us are shocked and are angry and are betrayed, but by those who we trusted, who are involved, who are proven to have been involved in corrupt activities, stealing from the people's purse, whether they are from the public sector or from the private sector, whether they are ANC members or members of the DA or members of whatever party, whether they are professionals or they are support staff, anyone found stealing, defrauding the state, defrauding the people of South Africa. We must have zero tolerance to corruption. We must commit, all of us, to implementing, amongst others, the Zondo Commission and strengthening the capacity of our anti-corruption efforts. And we must also welcome the fact that there is a collaborative effort of an adoption of an anti-corruption strategy at a national level, which I believe needs to be expanded to all levels at the provincial and local level, so that it's not only a national collaborative effort, but also at all levels of our society and government, that will join hands to fight corruption. South Africa is not unique in this regard. We must also benchmark and learn from countries that have been successful in this regard. But indeed, amidst all, there are those who have been in the public service, who have served this country with an impeccable record of stretching even the rent that is there. The rapid expansion of the clinic building program was also because there were standardized plans. You didn't have to, for every clinic, have an architecture. There were standardized, structures in line with what is required for health facilities. But we know that in other facilities, because of use of not the standards that are there, some of those facilities had to be rebuilt. A wastage indeed. There I agree with those members that have indicated so, including Member Clark as well. So we need to send, all of us, send a zero tolerance to corruption. Cost, I still look forward to, especially our previous minister being cleared of those allegations. I still can't believe that he could have been involved. But indeed, if he's found guilty, it would really be a great disappointment, and indeed not only to me, but to all of us, having served the public with distinction in terms of enabling us to ride this cloud of COVID-19. The issue of not getting value for money, indeed, there is more that needs to be done to account for every cent that we use, both in the public and the private sector. Because the cent we use in the private sector, it is medical aid funds, and medical aids are not profit-making institutions. They hold the contributions of employers and employees in trust. And I have no doubt, if we look at assessing that, like the Competitions Commission has done, we will find that there's a lot of wastage currently in the health system overall. Any guarantees that the NHI, when passed, will not will prevent financial hardships? We can benchmark with the countries that Dr. Moloko has referred to, and many other more. The knowledge is there globally that this works. And if it can work for the British, it can work for South Africans. South Africans also deserve to have protection from financial hardships as well. So there is a global experience that we can benchmark against, and that's why the world, the UN has included the universal health coverage in the SDGs. And what is comprehensive? I think the definition of comprehensive, the Act does refer to preventative, promotive, curative, and rehabilitative services. So it is important that contribution. We've heard from a number of health workers who were saying, I want to see the services by mental health workers there. I want to see the physiotherapy services. I want to see this and that service. I think, and indeed, this is one area that we need to all have comfort in and certainty on. But comprehensive refers to that. With a plethora of illnesses, you can't identify each one of them, but it is a standard definition guided by the WHO as well. Member Hlongwa, I think the issue of financial feasibility studies, I think if we can, there has been attempts, as we've referred to the Bloomberg-Sichana, there has been a number of studies done that since the democratic era, and the consensus, which, and I want to quote what President said, excuse me, he said that when introducing, when signing off, cabinet signed off this NHI bill, the president dealt with that concern because it is a bill that has been sanctioned by all of cabinet, both the ministers, all ministers, including the Minister of Finance. And President said in August 2019, and I quote, we have enough resources in this country to give every man, every woman, and every child healthcare. But we refuse because we want to promote the interest of the few to the detriment of the rest. We shall change this, and we are irrevocably committed to do this, close quote. It is important that we note that South Africa already spends, I think it's now 9%, it was about 8-point-something% of the GDP, of health expenditure, GDP expenditure on health. And this is far above the recommended WHO expenditure, percentage expenditure as such. So the resources are there. It is a matter of aligning all our resources to ensure that no one is left behind, and including not taking away from those that have, but ensuring that we assure them protection against financial hardships. Yeah, I think in terms of the impacts on quality of healthcare, the health compliance issues, I have addressed it, that yes, we have a long way to go, but reforms or transformation in the financing of healthcare will help fast track more health facilities to be compliant with the ideal clinics. Well, I guess there are those that are cynical, that believe that nothing constructive has been done with the ANC government since 1994. Maybe there's very little we can say to that because the South African people themselves must speak on that. And the South African people are the ones that have to be respected, their views, and that there are certain areas of life that we should minimize party politicking and rather ensure social cohesion and social solidarity. In terms of Honorable Member Siwela, The bill is not rational. The bill is not irrational, as others have alluded to. And I think I will not go more into details, but it will stand the constitutional scrutiny, as not only the scrutiny of law in South Africa, but the scrutiny of law within the African Union, and the scrutiny of law also globally. And where we need to tighten, I think let's look at how we can tighten, but we should all be vigilant that we work within the constitutional prescripts, understanding that the Constitution has made it very clear in the Bill of Rights that health is a fundamental human right, and no one must be left behind, and that the state must ensure progressive realization of this right as well. And the constitutional courts, it would be regrettable if this bill has to be challenged, but I have no doubt that should it be challenged, the constitutional court would interpret the rationality and the constitutionality of this bill in line with the constitutional prescripts that the South Africans have embraced. The issue of the powers of provinces is also a constitutional matter and needs to be resolved constitutionally. When we hosted the World Cup, the Soccer World Cup, we ensured that we have seamless legislation in the best interest of the ability of the country to succeed. We set as the 3 spheres and we aligned our various powers. So we hope that indeed through this act, because it's a 76 bill, as it goes to the NCOP and provinces, there'll be concurrence, especially for those that really believe this bill cannot be delayed anymore or enactment. The role of the Minister of Finance. We have a tendency of sending everything to the Minister of Finance, who have their own primary responsibility at the macroeconomic level, at ensuring the fiscal management. We have these other ministries so that these ministers can earn their positions. But we agree with those that say there must be checks and balances, including that Parliament must also execute its responsibility, that the law enforcement agencies, the AG's office, independent agencies, we have just strengthened the capacity of the AG's office to appoint at wrong and also to ensure accountability. So we have learned as a young democracy to strengthen the checks and balances, and that we were able to identify during COVID the shenanigans, the corruption, the irregularities that were there, and also reclaim the money lost, some of the money lost. It shows that we are determined and we should be resilient. Corruption cannot defeat us as a formidable nation. We must defeat it. So the Minister of Finance has his primary responsibility. Otherwise, if he executes, who is going to ensure also oversight in terms of resources, resource management? And also there are those that are saying the president should also have a say. Perhaps the portfolio committee could consider the appointment of the board by cabinet at the recommendation of the Minister of Health in this regard. That's another option that we are open to. However, if you constrain the capability of the Minister of Health to manage the health sector, it would be a greater risk to the health system and the health of the people. Honorable Geller, I think Honorable Sokacha, it's the issue of a single funding pool as a purchaser, role of medical schemes. I think Dr. Moloko has dealt with that. We're not averse to medical schemes being a top-up to a mandatory contribution. The principles that we believe would make the NHI project successful in the best interest of South Africans are the principles that we have sent through in the detailed submission, the principles of health as a right, universal access, that it is free at the point of use, that there must be choice of a provider within the district, mandatory contribution to pay, but according to ability to pay, that is social solidarity, and also that no one who is eligible will be allowed to opt out of the NHI. And if these minimum principles have been accommodated in terms of the NHI fund so that it is sustainable, then I think we can actually engage on what South Africans they have to top up. If I want to do plastic surgery to my nose, maybe make it smaller, make it bigger, whatever. And there is a medical insurance around that. I guess the comprehensive healthcare services, basic healthcare services, comprehensive, including tertiary services, would be catered for, and that could be what the medical aids pay. So I think it's an issue that can be looked at, but after the mandatory contributions have been met by everybody who is expected to. In terms of Member Gela, reasonable targets for health expenditure of the GDP, I think we've already heard that the expenditure of GDP to health already in South Africa is reasonable. It is how we use it, both in the public and private sector as such. And a lot of ordinary South Africans can get better outcome out of that health expenditure already. The cabinet committee to appoint the board and a board. We have made a submission here that the board should appoint the CEO in consultation with the minister as a safeguard, but also for the board to also be empowered to hold the CEO accountable as an accounting authority. Member Chilidzi, constitutionality, we've talked about it, freedom of choice. I did allude to choice at the district level, and the issue of the bill being regressive, we did talk about it. I think the constitution is indeed progressive. The UN system is progressive so that no one is left behind. So I don't understand, or maybe the member or the people who believe that needs to be assured that they will not be left behind. I don't know how else we do it except through this process. Slide 17, the role of multilateral structures. I think Dr. Moloko has dealt with it. Challenging the powers of minister, I think that we've dealt with it. And that taxation, all public services which the state is accountable for, they come from tax. It's a contribution, and the NHI should, or the NHI fund should not be treated differently. Honorable Chair Jacobs, the contradictions on Minister of Finance not supporting. At some stage when I presented this matter, because I was requested to chair the NHI task team by the African National Congress, I presented this matter and I was asked to provide evidence by the leadership of of government, that if I have evidence, I must provide it, and they will only respond to me if I have evidence, because they have no evidence that any Minister of Health, any Minister of Finance is against the NHI, because this bill is a bill from Cabinet as a whole. It was signed off by the whole of Cabinet. So I also call on yourselves, honorable members, or any member of the public whatsoever, if you have evidence of any Minister of Finance or any official in finance, in the finance department, who is against the bill, perhaps we have to listen to them, maybe make them understand that actually this will enable the country to be more productive. It will enable the economy to even recover better, and it is also a constitutional obligation that they have to look at it, to assist us on how to do it in a manner that they think could succeed, other than them being a barrier. We hear this, it's just a rumor. I haven't been able to, I've made in all my meetings, I've called for evidence, and I've addressed the business sector, I've addressed health professionals, I've addressed many, or we have as a task team on NHI in the ANC. We've addressed many forums. This matter keeps on coming, but we as yet don't have any evidence thereof. The last issue that you've raised, Honorable Chair, is that based on the lessons from COVID, what lessons can we take from COVID? I didn't really get the issue of testing resulting in marginalization of the poor at all. But I have seen many testing sites in the private sector being able to also test the poor and then billing government. But there are those, including myself, I was chased away from one of the testing centers in a private hospital. After I was called to come and take my vaccine against COVID, I went there, but I was chased away because I didn't have a medical aid, medical insurance. However, I was able to access the same from another private health facility, which sent me an invite, and I went there like anybody else, not asking for any favors. And many other people were asked to come with medical aids, went to the public sector, and they were awed with the quality of service, that the professional service they received. So if there's one thing that we must take from COVID, is that there is just one country that we belong to, and that is South Africa. And that the constitution of the country protects all of us and accords all of us the right to quality healthcare, and that the NHI brings us closer to universal healthcare. And some of the principles include access to services on the basis of need. The state must bear a constitutional obligation to provide access to healthcare services, and the state is obliged to provide the needs of those with the most urgent need for care. When there is an injury on site, we categorize priority 1, priority 2, priority 3, according to the injuries. And you can have someone airlifted because of the severe injuries compared to the others. And then funding of services being based on assessment of need, as well as the NHI being publicly funded and administered. Those are the principles that we believe would make the NHI Act sustainable and serve South Africans better. Thank you. I think we did say we didn't hear the question from Member Harvard.
Member Howard, thank you very much, Dr. Ramakopa and Moloko, for those responses. Member Howard, are you able to raise that question now? I must also be mindful, honorable members, that the sitting is starting at 2 o'clock. And I still have a number of points I need to discuss in the portfolio committee. So, Ms. Member Harvard, as you might have left to attend the sitting. Are you here, Member Harvard?
Yes, Chair.
Can you repeat your question, please?
Okay, thank you. Thank you. I'm just repeating my question again. Can the ANC clarify further why in slide 24 says that the issue of extra taxation is a myth? Thank you.
Yeah. Did you understand that? Okay, the question speaks to
Chair, is it the issue of extradition?
the extra taxation, yes, at the moment.
Extra taxation, okay. I think I have asked Dr. Moloko to also respond, to give a response to that.
Turn right.
We have, as the ANC put it very clear, that the bill gives the details of the sources of funds and the manner in which the issue of extra taxation is being raised is relatively misleading, as the sources of funds from the current the current resources that are available, and it will be from tax, it will be the contribution from those that can be able to contribute, including the employers, and wherever it is necessary, what will be done is that there will be money that will be allocated for the fiscus, especially for those people to cover those people that would not be in a position to contribute. There are just a few questions that I thought, Chairperson, if you allow, that had not been covered, that were very direct. And I thought that maybe if we cover them, the rest of the questions, then we could be, because of time, leave them for us to answer them in writing. Can I proceed, Chairperson?
I could give you 3 minutes, Dr. Manu.
I cannot, I don't hear well, Doctor.
I can give you 3 minutes. Thank you.
Okay. Yeah. On the issue of the powers of the ministers, my plea is that the portfolio committee should accept the fact that when we make the laws, we do not make them for individuals. They are also not being made for political parties, but they are made for a government, for structures, for systems, so that they can then be able to run. On the issue of that was direct, that was a question that related to immigrants. I just wanted to highlight here that because it was said, how is it going to be done? The portfolio committee would in fact be requested to, in their oversight, interacting with the National Department of Health and the National Treasury, because they have been directed that in collaboration, they must develop measures that help budget allocations takes account of population movements. So not only the external or from other immigration from other countries, but also the population movements that are inside the country. It went further to say measures should be developed by the health sector to address the burden on the health system that is a consequence of international patients using the public health system without assistance provided by sending countries or international health agencies and institutions. So this is one issue that the National Department, the Department of Health and the Treasury can be held accountable for. There was also a question around litigation. It has been said that for us to be able to resolve the issues around medical malpractice, medical insurance, and litigation, this hazards must be decreased through improving clinical care, introducing mediation, and the use of legal tools. And this was said because it was realized that the problem of medical malpractice, medical insurance and litigation is not only affecting the public sector, but it affects the private health sector too. So the policy on curbing high cost of medical insurance and litigation against medical malpractice should be developed. And we will be looking at that to check and see as to whether this work is being done or not. There was a question that was asked by Ms. Wilson as to what people are paying at the clinics. At the clinics, people are not paying. And I think that maybe it is at this point where we should put it very clearly that if we are talking about the district health system, at the top of the pyramid of the district health system, we have got a district hospital. And the human resources and other resources that are going to the community health centers and the clinics, they are usually accounted for by the systems and the structures that are existing at the level of the district hospital. That is the reason why the district, the primary health care has always had at its top a district hospital. And the regional hospitals and the academic hospitals and central hospitals have been in what we call the hospital services, even in terms of the structure of the Department of Health. We should also note that the issues that have been raised about the central hospitals, they are in fact said very clearly in the National Health Act, where the central hospitals belong to the it's a national competence. I will just there was also a question that was saying taking money from Peter to Paul, and I would say that take the money that we are talking about for the NHI. There is no money that belongs to Peter, and there's no money that belongs to Paul. All the money belongs to the people of South Africa, and the ANC would like to have a unified system where the money belongs to all, not to Peter or to Paul. Thank you.
Thank you very much. Anyone else? Is Ms. Potgieter going to say anything? I'm about to close this section, Dr. Moloko. Honorable members, we've just received the presentation from the African National Congress. I want to thank the presenters, all three of them. Of course, we are reminded about our role, and we've also been reminded in the presentation and the responses to the question that our role is to recognize that healthcare is a fundamental human right, and also as a reminder that the objective of the NHI bill is to provide universal access to quality healthcare for all South Africans as enshrined in the Constitution, and that we have an obligation as the legislative arm to do these hearings as we have been doing for the past 2 years, to do our work, which is to then pass legislation. With that having been said, I am going to provide final opportunity to one of the two, of Dr. Moloko or Ramapopa, to do some concluding remarks, and then we are going to deal with some other issues very quickly, honorable members. And I'm really trying to speed up time, recognizing that we have a sitting at 2. Dr. Ramapopa or Dr. Moloko?
Just going to in conclusion. Okay. Thank you very much. Very briefly, Chairperson, Honorable Chairperson and Honorable members, thank you very much for this opportunity. I think that the work that Parliament is doing on reaching out on the National Health Insurance Bill is so critical, because this is a very important bill that goes to the heart, not just of our Constitution, but also to the long struggle that we refer to in our input. In slide 14 of our input, we talk about, based on what the World Health Organization referred to as the systems building blocks. It talks about service delivery, it talks about information, it talks about human resources, and it talks about finance as amongst the building blocks of a national health system. And therefore, this is very critical part of that, because Your finance speak to all of those other areas. And this is therefore an appeal to Parliament to ensure that this bill goes through, that the necessary improvements are being made. But it certainly is an important milestone in the history of our democracy. And thank you very much to the Health Committee for spearheading this process. And thank you very much to Parliament.
Thank you very much again. Honorable members, you are welcome to stay on for a few minutes. There will be a time when I'm going to request all of those who are not members of the Portfolio Committee or the host for the committee secretary to keep our platform for something very special we want to talk about. But right now, my job is to thank all of the honorable members for the work that has been done. Indeed, the Portfolio Committee on Health was the very first Portfolio Committee to hold virtual meetings, and we are also the very first committee to have done these public presentations or representations on a virtual system. So I'm very proud to announce that we have concluded the virtual public participation on the NHI bill, which has started on the 18th of May 2021. Of course, this followed the provincial public hearings, and I'm doing this purely as a summary, which have taken place between the 25th of October 2019 and February 2020 across 33 districts. We have had 961 oral submissions, 338,891 written submissions, including 283,009 accompanying email submissions and 681 and delivered submissions. We have completed one further processes with regards to this work that we're doing as a portfolio committee will be indicated by the secretary of the portfolio committee. And I want to applaud your honorable members. I also want to applaud our committee secretary and other staff members, Mr. Bandi, who's been leading this from the Parliament side as the unit manager, our content advisor, our researchers, and all other staff who have been assisting us. Honorable Ismail, yes, I've noted what you asked, and we are going to ask the committee secretary to make certain that your point is captured within the minutes of today. For next week, honorable members, we will be receiving the Commission for Gender Equality, 2 reports from them. One is on the state of shelters, and the second one is on the report on the bound by duty care, assessing the correctional services centers on the health and welfare services of female offenders. Then we will be considering and adopting the minutes of the 15th, 16th, and of today's meeting. And then I will give us Majalamba very shortly to give us an indication of our progress with regards to our application or our discussion and writings about our study, our envisaged study. 2 minutes, less than 2 minutes with Majalamba.
Good afternoon and thank you, Chair. I have submitted a letter to IR requesting them to assist us in organizing the study tour, and the country that has been identified is the UK. The committee will travel on the 25th if it's approved, 25th of March, and return on the 2nd of April. Thank you, Chair. We are waiting for their response. Thank you, Chair.
Thank you very much. Honorable members, we have come to the conclusion of this part of our meeting. I have indicated that I'm going to request all other persons who are on our platform to please excuse us. We are going to retain only the members of the National Assembly or members of the Portfolio Committee on Health, and our committee secretary and or host if it's not the same person on our meeting. So I'm going to give you a minute or so to leave our platform. Thank you very much for joining us once again. And we appreciate all of the inputs which were given to them. Thank you. Honorable members, just stay on the platform, please. It includes members of the media and Ms. Majalamba will assist me to ensure that it's only us on the system, the ones whom I have